Good morning, everybody. I am Dr. Vinita Ramnani, Secretary, Bhopal Divisional Ophthalmic Society. I welcome you all for this pediatric ophthalmology webinar. And we have a galaxy of speakers and panelists with us. And now I invite Dr. Lalit Shrivastava, our President, to welcome our guest speakers. Dr. Lalit.
Okay, hello to everybody. Yeah, good morning to everybody. On behalf of the Bhopal Divisional Ophthalmic Society, I welcome you all in this wonderful webinar on pediatric ophthalmology. I would like to welcome you all for today's CME on pediatric ophthalmology. It is a pleasure to introduce you all eminent panelists and speakers for today's meeting. We have Professor Dr. Subhash Gadhia, Director and Professor Guru Nanak Eye Center, Maulana Azad Medical College, Delhi, and President of Delhi Ophthalmic Society. We welcome you, sir. Hearty welcome to you, sir.
Thank you, sir.
We also welcome our Chief Patron, Dr. Shailesh Kumar Sahab, our Chief Patron, as well as the Professor of Ophthalmology, retired from Regional Institute of Ophthalmology, Gandhi Medical College, Bhopal, who has been prolific academician and great teacher. We welcome you, sir.
Thank you. Good morning.
Dr. Shashikant Sethi, Chief in Pediatric Ophthalmology from Arvind Eye Hospital, Madurai. We also welcome Dr. Sunita Agarkar from Shankar College, Chennai, who has her expertise in congenital cataract. We heartily welcome you, madam. We also welcome Dr. Ajay Bankar, vitreoretinal surgeon at Banker's Retina Clinic and Laser Center in Ahmedabad, and is a fellow of University of California and fellow Shankar Netralaya. We welcome you, sir. We welcome Dr. Jitan Jethani, international repute pediatric ophthalmologist at Baroda, Children Eye Hospital, Children Eye Care and Squint Clinic, senior editor, pediatric ophthalmology, Indian Ophthalmology, ex-president, Baroda Ophthalmic Society. I would like to welcome all the other speakers for today's CME, Dr. Kavita Gupta, Dr. Rasmi Apte, Dr. Pavan Chaurasia, Dr. Vinita Ramnani, to continue the session onwards. Thank you for everybody.
Thank you, Dr. Lalit Shrivastava. Thank you so much. Now, our time, we should start with our first talk, which is salient point of pediatric refraction and prescribing glasses in nutshell, which is very important and I think is the best topic to begin with pediatric ophthalmology. Dr. Kavita, can you share your screen, please?
A very good morning to all of us. Ma'am, am I audible?
Yes, yes, yes.
Thank you, BDOS, for giving me this opportunity to be a part of this webinar, Spectacle Prescription in Children. The simple guidelines for glass prescription: refraction, 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 and only refraction. I would say without refraction, we can't even think of prescribing glasses to children. Cycloplegic drugs for doing refraction to paralyze the accommodation. We use cyclopentolate, homatropine, and atropine in that order. Cyclopentolate is most commonly used. Homatropine is used in those cases where we get a history of seizures in a child. Atropine is used in those cases where the pupil is non-dilating, highly pigmented iris is there, or in accommodative esotropia. The salient features of common cycloplegics are atropine sulfate 1% ointment, TDS for 3 days. We call the child after 2 to 3 days. The action lasts for 10 to 20 days and the tonus allowance given by it is 1 diopter. Homatropine hydrobomide 2% drops, 1 drop every 10 minutes for 6 times. The action comes in 60 to 90 minutes, persists for 48 to 72 hours, and the tonus allowance provided by it is 0.75 diopter. Cyclopentolate hydrochloride 1% drops is used, 1 drop every 15 minutes for 3 times. The action comes in 80 to 90 minutes. The action lasts for 6 to 18 hours and the tonus allowance provided by it is 0.50 diopter. But in our OPD, we usually follow the rule CTC. That means we put a 1 drop of cyclopentolate followed by 1 drop of tropicamide followed by again 1 drop of cyclopentolate at an interval of 15 minutes. 40 minutes thereafter, the cycloplegic effect is attained and we do retinoscopy. The objective of my presentation is the guidelines for myopia, hyperopia, and astigmatism correction. Why do we want to prescribe glasses in children is my question. Only to correct refractive error? No. We have to consider the visual demand of a child. We have to consider the accommodative ability of a child. So, what is important? Individual experience is important. What do I mean by the visual demand? Meaning is this, that if suppose an 8 to 9 month child comes to us, that child has -2 diopter myopia. Yes, this refractive error is important, but the visual demand is not much at that point of time because the child world is near. Then the accommodative ability in certain patients like Down syndrome, corticovisual impairment, developmental delay, these patients have disturbance in accommodative ability. So we have to prescribe some plus power to facilitate their accommodation. Now, what are the guidelines for prescribing glasses? Before prescribing glasses, we should always think that whether that power which we are giving is amblyopia-genic, whether the visual demand of a child is such that we have to prescribe glasses, and whether the error may cause any effect on the strabismus if present. So every prescription needs to be individualized. Hyperopia. What are the guidelines for correcting childhood hyperopia? It is mandatory to give full correction only in presence of esotropia or esophoria. Moderate to high degree of hypermetropia require correction to achieve good visual acuity. Above 2 years of age, more than 4 diopter needs prescription. When we prescribe glasses to a child, 5 plus glasses, then what happens is that sometimes the accommodation may not relax. So we should give some cycloplegic to that child so that we can relax the accommodation and the child gets adapted to glasses. 1 or 2 times of homide we usually prescribe for 2 to 3 weeks, and gradually we see that the child gets adapted to those glasses. So in a nutshell, I would say that the child may not require full correction, reduce equally in both eyes without compromising the visual acuity. If you find that esotropia is present, give full correction, and if no esotropia, tune your correction. In myopia, we usually see that hypermetropia patients have more chances of getting amblyopic. So myopia, it entails less risk of amblyopia, no doubt, but if myopia is present and if it's greater than -4 diopter, then need to prescribe glasses and it may cause blur which leads to amblyopia. Full correction for school-going children and overcorrection may cause accommodative spars leading to severe asthenopic symptoms and esotropia. Only one condition is there where over minus glasses is prescribed, and that is the case of intermittent divergent squint because it helps for accommodative convergence to control exotropia. So in a nutshell, always give full correction but never undercorrection in myopic patients. Now, astigmatism. If suppose only cylinder is present and the child is less than 3-year old, correct only if greater than 1.5 diopter cylinder is present. And if the child is greater than 3-year old, we have to prescribe even if 0.5 diopter cylinder is present. If cylinder is associated with spherical power, give full correction. Anisometropia of greater than 1 diopter is more common in infants than adults. Anisometropia is transient in relatively lower level of refractive error, that is 2.50 diopter or less, have lower chance to develop into amblyopia. We usually see that at birth, the child usually is hypermetropic and can have some astigmatism. And by the age of 3 years, nullification occurs by the process of emetropization. There is more myopia in premature children. Coming to esotropias, we have to prescribe the full cycloplegic refraction in accommodative esotropias. In case of distance and near disparity, with greater esotropia at near, we have to check with +3 addition power, and if there is high AC by A ratio, we have to prescribe executive bifocals bisecting the pupils with addition of +3 diopter lenses. In cases of exotropia, we have to correct the myopia and astigmatism. Full correction is to be given. We have to undercorrect the hyperopia and over minus glasses in some cases of intermittent exotropia in order to stimulate accommodative convergence, which helps to control the exotropias. There are certain special situations where we operate a child for cataract and we leave the child aphakic. If suppose the child ages less than 3 years, 3 years means the child world is near. So if the child ages 0 to 1 year, if the child ages below 3 years, we have to provide unifocal or the single vision glasses. If the child is 0 to 1 year, we have to add +3 to the power. If the child ages 1 to 2 years, add +2 diopter spherical. And if the age is 2 to 3 years, distance +1 diopter spherical is to be added. When we implant the lens, that means if the child is made pseudophakic, then we have to give the bifocals and in the form of executive or progressive glasses. Other special situations, the condition of developmental delays, Down syndrome, corticovisual impairment, where there is accommodation insufficiency, it is best to give +2 to +3 to improve the focusing ability. Accommodatives sometimes present as pseudomyopia, but actually is not myopic. So I would like to discuss at this point of time that when I was young in my school days, in the 7th or 8th class, then I told my parents that I have problem in my reading and I feel tiredness during studying. My uncle was doing MBBS at that time. He took me to the medical college where I returned home, and then again gradually I thought that I have no refractive error, my eyes are all right. But then one day I told my parents, no, I'm not satisfied. I'm really having problem in reading. Take me to some other doctor. They took me to the private practitioner. He did my cycloplegic refraction, and then +2 diopter spherical power was given to me. And really, I tell you that when I received those glasses, I had lot of comfort in my eyes, and I said thank that to the doctor that he did that refraction and solved my problem. So I want to highlight that how much important is cycloplegic refraction in order to relieve the child from symptoms. Now, in ROP children, these children can have myopia, so we should rule out. Now, American Association for Pediatric Ophthalmology and Strabismus guidelines on the use of glasses for children. So there is a guideline given which we can follow. Otherwise, the individual experience teaches us a lot. Now, tips for selecting frames for kids. Thickness of the lenses. Frame should be small as it reduces higher order aberration near the edge of the lens, and there are less risk of blurred or distorted peripheral vision. Sometimes if we give the child the photochromatic lenses that automatically darken in sunlight, which helps to inspire the child to wear glasses. Better choice of frames we can choose, which plastic or metal, which are less likely to be bent or broken, light in weight and less expensive. Now, the very important point is proper bridge fit. Sometimes I've seen in my OPD that the child comes with the parents and the parent says that the the child is not using the glasses. He or she look over the lenses. So before saying that the glasses prescription given right or wrong, we should always look at the type of frame which that child is wearing. Because what happens is that the kid's nose is not fully developed. So we have to see that whether the bridge of the frame and the nose, is there any gap between them? If there is any gap, then what happens is that the weight of the lenses will cause the glasses to slide, and the child tends to look above the lenses. So we should always see or look the frame which the child is wearing, whether it is proper or not. Miraflex frame is commonly used, and lens material in children CR39 is used, and polycarbonate is basically preferred in those cases with a single-eyed patients or like that. So I would like to say that spectacle prescription for children is an art requiring interpretation. The child's refractive error and visual acuity within the global evaluation of a child. Thank you.
Thank you, Dr. Kavita,
Very
for
nice presentation.
elaborate presentation on refraction. I would like to invite panelists that how they proceed for their refraction in pediatric age group. And I will request those who are speaking only keep their mic unmute. Otherwise, rest all during others talk, please unmute themselves. It's a request, please unmute themselves. Dr. Subhash Dedia, what is your protocol of
I think
prescribing glasses?
Dr. Vinita, Dr. Kavita has covered the topic very well and very nicely, and all relevant points have been taken care. But only thing I would like to add one comment, because I routinely do the refraction under atropine up to 6 years of age, and after that we can use hometropine or cyclopentolate as maybe the procedure, and it is individual choice. Otherwise, she has covered every point and very well. So it is more or less same procedure is being followed, only with exception that I use atropine.
Sir, you use atropine eye drop or eye ointment?
Eye ointment.
Ointment. Thank you, sir. Dr. Sumita, how do you test vision in children at your place? I think Dr. Sumita is not there. Dr. Jitain, are you there?
Yes, ma'am. I think
Dr. Jitain, just tell us how to do a vision in children. That's the biggest problem.
I think vision in children, there are a few things we should look for. I mean, we should have the age appropriate charts for sure, but we should also it's a slightly more time consuming process, so we should give some time to the kids. We should try to see that they are comfortable, because unlike adults, most of the kids are not coming to our clinic because they want to come. It is the parents who have told them that they have to come to a eye specialist. So they are more like, they are not very cool about it. So you have to give them their time, and you can repeat their visual acuity a couple of times. I think they perform much better even without amblyopia on single optotypes. But we should try to first make them comfortable on single optotypes, and then definitely check on crowded charts, because otherwise we may miss that they have amblyopia or other problems. Also, when they are very young kids, you can use the CSM method, which is central study maintenance fixation method. So that gives you a good clue. With strabismus, it is much easier because you can see which eye is fixing and whether one of the eye, whether the patient is able to alternate or not, and that can be helpful. So these are some of the easier ways of helping out with kids when we are checking their visual acuity.
Any special chart you are using?
Well, we have long back we had shifted to using video-based visual acuity. I mean, the Unisys chart, which is there. We have been using this now since almost 10 years. So it has single optotype, it has Allen preschool, it has picture charts, it has single optotype, crowded, stereo, word for dot test. It has all the tests. So I think it is a good way of doing it. More importantly, because now children have shifted to mobiles and computers, so they connect easily with that. They also have videos. You can show them when you are doing a Buckner test or you are doing retinoscopy. They have videos with audio feedback. So you can, these things do help when you are examining a kid.
Thank you, Dr. Jethani. Dr. Sumita, what's your take home on refraction in a child?
I think she has done very eloquently, covered almost everything. So importance of cycloplegic refraction is undisputable. There is, so do not give any prescription of glasses without cycloplegia. At least the first prescription of the child should always have cycloplegia. Second, as he was saying, Leah symbols is now easily available, and most people should have that because it's very easy for other, like we do have Cardiff and Taylor Acuity card in our institute because it's an institute. But Leah cards are very easy to record in pre-verbal children. There are only 4 symbols, can be translated to Snellen's, and I think it is not that expensive also. And it's a 3-meter chart, so chances of errors are, though it tends to a little bit overestimate compared to Snellen's, but to give you some kind of quantitative assessment of vision, Leah symbols is also a very good option in children. And yes, if you have this Compulog,
Dr. Shetty, any difference from?
Nothing better than that.
Thank you, Dr. Sumita. Dr. Shetty, is there any difference what we have discussed till now? Sir, you have to unmute yourself.
Sorry. We usually use the Teller Acuity cards. Less than 1 year, we use the CSM method. And 1 to 3 years, we use the Teller Acuity cards. 3 to 5 years, we use the picture cards. And then above 5 years, we use the Snellen's chart. So Dr. Jitendra has correctly put out that you have the automated screen now where everything is available and you can screen the children. No? And they're also happy to look at those videos and this thing. And for refraction, one of our slides showed like giving +3 diopters as a bifocal ad for accommodative non-refractive esotropia. We usually start depending on the AC by ratio and amount of, and we don't go for the full +3 diopter ad. So basically we need to start with the lower amount, and depending upon the deviation, what you are inducing with that ad, and then you slowly you need to push up the plus side. We don't have to start with +3 ad. Now depends on the AC by ratio and how much deviation is getting corrected by the minimum amount of plus side, because it becomes difficult then to later on to taper off the bifocals as the child grows older, and we need to take care of the emmetropization also. So otherwise you make the child dependent on the bifocals. Otherwise, Dr. Kavita has covered everything well. And usually below 5 years of age, we usually use atropine for refraction, and above 5 years of age, we use the cyclopent this thing. Unless the child has got history of febrile seizures or history of seizures, then we avoid cyclopentolate because it usually it can cause delirium and other issues. So then those patients we use hometropine.
Yes.
So just one thing which I want to ask, like in cases with Downs or cortical visual impairment or delayed milestone, as has been pointed out by Dr. Kavita ma'am, do you always go for bifocal to begin up with in such cases?
No, we should not give bifocal. They will not look through the bifocal. No, we should do a MEM retinoscopy, and you have to look for the lag of accommodation. Okay, so depending on the lag of accommodation, you have to prescribe the plus lenses for these kids. And in Down syndrome, they say because most of them have hypoaccommodation, so you need to assess their accommodation ability. You need to look at their accommodation amplitude of accommodation and how much use a RF ruler. And then you can use the flippers, and also you can use the to look whether they have akinase of accommodation. Most of the time they have some problem with their accommodation issues. So if they have accommodation insufficiency, then bifocals will help. You have to give some plus side for them. If the child is little older, no, we might has to look through the bifocals. Because if you are giving bifocal and the child is not using that bifocal, then it will not be of any use for those patients.
A lot of Down's children, although don't like wearing glasses, they don't like anything on their face. Correct. So what Dr. Shetty is saying, you do flippers and RAF, practically speaking, very, very difficult to measure that. I think lack of accommodation is something which very easily can be done.
Yes, yes.
So, and that gives you a good idea about how much is the accommodation. A lot of these children will do well with their just whatever prescription they are getting. Instead of making it very complicated and bifocal and child not wearing, finally it will come to you with glasses intact in the case 3 months later. And the child would not have gone. Yeah. So sometimes it's useful to just give the preliminary prescription. And if you do suspect lack of accommodation on MIM, which again, MIM can be done very, very easily, even in very uncooperative children. So instead of flippers and all, I wouldn't worry about that much with Downs, but probably MIM information is something which can be provided very quickly in 1 minute.
Yeah, actually,
just flashing or doing retinoscopy. So that will tell you about accommodation if there is a real big lag.
Yeah.
Otherwise, a lot of these children are very, very reluctant to wear glasses. They don't like things on their face. And that's one problem. So if you can get a good refraction and give that itself solves a lot of issues rather than subjecting them to testing, which prolongs the examination, and in the end, you will have information which you may or may not want to use.
And we usually prefer to give them D-shaped bifocals and larger segment D-shaped bifocals, which are actually good. We should avoid giving those cryptoc bifocals. D-shaped bifocals are good, larger segments, so they will use through these lower segments.
Why not executive, Shetty sir?
Executive is also good, but it's little expensive and compared to, I don't know, because here they're finding this executive is little expensive compared to the D-shaped. So, and they find it difficult because most of the time this executive, they're not properly done. Sometimes it just slides down and most of the kids will be looking through those upper segment only. So I'm not very sure about that. Jitendra, what you give executive bifocals to them?
We give executive, sir. So you can actually, what happens is that all us ophthalmologists know we are not very good when it comes to opticals, because we believe that opticals is something which opticians should take care of, and they would never see them from your perspective.
Yes.
They see them from their perspective. Since executive is difficult to make, they will say, why not make D bifocals?
Yes.
See, if the glass is shifting down, D bifocals is same as executive.
Also same, yes.
Executive, you can put it at 60% also. Whatever you want to do, you can do. If you buy a slab and you tell them to make it through the slab, you can mark it whatever way you want to.
Dr. Salil sir, do you want to add something?
I go with Jitendra, but one thing is there that executive is difficult to make, and very few opticians, they are expert in making executive bifocals. So if there is a cylinder or if the power is properly made and the segments are proper, then it's okay. Otherwise, it's very difficult for a child and he will not accept the glasses. So I go with Jiten. You go for executive, but the optician should be a very well trained optician, because these days in every city you find everybody is opening an optical shop and making glasses. So for that, optician should be very good.
The problem is that the reason why this problem has come up is because some 15 years back, what used to happen was in India, the opticians used to make their own, with the help of the dye, whatever you prescribe, they used to make glasses. But because of the Chinese invasion into the market, they have made sure that they have made dyes and slabs of all the powers. Now, the executive market is not a big market, and it doesn't look good when adults are wearing it. So the market is very small. And the local people who are making glasses are no more making glasses. So everybody is using all the things are coming from China. So now we have to bank upon Zeiss or Kodak or Essilor to make executive bifocals, which are obviously branded, and so they become expensive.
Okay, thank you so much. Now we move on to our next talk, which is practical tips of squint assessment in children by Dr. Rashmi Apte.
Good morning, everybody. I am very much honored to be in your esteemed presence today morning. Before starting examination, we must have goal in mind what to examine and for what reason. So first we have to rule out the pseudo squint part. Then we have to see whether the squint is there since birth or it is acquired later on. Then we have to see for paralytic or restrictive component. Then sensory and motor evaluation is done, and then measurements. In this era, we must prognosticate a patient. Suppose we are doing 100% squint surgery with 100% alignment, but we have not told about amblyopia or no improvement in vision. The patient will never be satisfied. The inspection starts when a patient enters your clinic, and when you are examining a child, make him comfortable first. Don't jump upon examining. So see for the facial asymmetry, which is very much associated with congenital superior oblique palsy. See for preauricular tags, they are associated with DRS. Then we have to see the broad nasal bridge, epicanthal fold, upslanting palpebral apertures, because they are very much associated with pseudo squints. Then we have to see for head tilt and face turn. We all know that head tilt is the inclination of the head towards shoulder, and face turn is when the face is turned to right or left. Simultaneously, you can ask history from parents. First, we have to ask about the onset, whether gradual or sudden. Any association of fever, trauma, or vaccination should be asked. Then you should ask for family history, obstetric history, or developmental history, because developmental delay patients have lot high association of squint. We have to ask for double vision. Many parents complain that child is closing one eye. This is an attempt to avoid double vision. And then we have to see whether it is alternating or in one eye only, whether it is constant or intermittent. If intermittent, we have to ask for the frequency, for how much time the child is squinting. Then we have to ask for the previous treatment taken for squint, and if previous photographs are available, we have to opine accordingly. The examination starts with the torchlight held at 14 inches. 1 millimeter decentration signifies 7 degrees of squint. So if the pupil corneal reflex is in the center, it's normal. At the pupillary margin, it's 15 degrees. In between pupillary margin and limbus, it is 30. And at the limbus, it's 45 degrees or 90 prism diopters. A pediatric ophthalmologist should have lot of patience. So in all the developmental delay cases and in infants, we have to wait to click a photograph till the child makes the head straight. Then only we can rely on the corneal reflex, because we have to do surgery according to this reflex. But we have to keep in mind the angle kappa. This is the angle between the pupillary axis and the visual axis. Usually 5 degrees of decentration nasally is common, but if it is more, then there are chances of pseudo squints. Cover test will confirm your diagnosis of squint, but the prerequisites are good visual acuity, more than 660, and foveal fixation should be there in both the eyes. 3 tests are there in cover test. First is the cover test to establish tropia or manifest deviation, then uncover test to detect phorias or latent, and then the alternate cover test to detect both. This is needed for squint dosing of squint. What are the things to be remembered? First, the apex should be there towards the deviation side, both in vertical and as well as in horizontal deviations. Then if we are using prism bars, that is to be kept in pentized position, that is parallel to the cornea, or the light should enter at 90 degrees. But if we are using loose prisms, that should be kept in frontal plane position, because the prisms are calibrated accordingly. Now I will start with the cover test. Cover test is to look for manifest deviation. Here, the uncovered eye is looked. Like I am occluding the left eye, we have to see the right eye. In this video, while left eye is being covered, the right eye is making inward deviation. So the right eye is having manifest deviation. To label a deviation as alternating, we have to wait till the next blink, because if after a blink the child is keeping the same position, then it is alternating. Then it is uniocular. Then next comes the cover uncover test. When the manifest deviation is not there, we have to elicit the hidden deviation or the tropia part. Here I am covering the right eye, but there is no movement in the left eye. The child was not very uncooperative, so he was making some funny movements, but there is no tropia, there is no manifest deviation. So now I have to see the eye under cover, which is uncovered. After breaking the fusion, the child is making inward movement, so the child is having latent exodeviation or phoria. The third part is alternate cover test to elicit both the components. Simultaneously, I am measuring the amount of deviation also. Like in this, I am increasing the power of the prism bar. Here I want to stress upon that if the power of the deviation is more than 40 prism diopters, then instead of stacking the prism bar, we have to split the prisms. So I am asking the patient to hold 45 prism diopter prism in front of left eye. And then again I will measure keeping the prism bar in front of the right eye. And here it should be noted that it is not the algebraic sum, but it is slightly more than that. Suppose 20 comes in right eye, then it is not 65, but slightly more than 65. So we have to consult table by Rosenbaum. Vertical prisms can be stacked, but not horizontal prisms. This is a video of right eye esotropia with hypotropia. So vertical prism is stacked behind the horizontal prism bar. Next, the prism bar cover test should be done in up gaze and down gaze. We have to ask the child to keep his chin down to see in up gaze, and in reverse direction to see in down gaze. There are certain adjustments according to glasses. If the glass power is more than 5 diopters, we have to do adjustments. Always remember that minus measures more, both in ESO as well as in EXO. Again, we have to consult a table by Rosenbaum. We have to see for primary and secondary deviations. If paralytic component is there, secondary deviation is sound eyes deviation, which is always more in paralytic squint. But surgery is done according to the target angle in the squinting eye. What if the vision is not good? If the vision is not good, we have to rely on corneal reflex test, that is modified Krimsky's test. In modified Krimsky's test, prism bar is kept in front of the seeing eye. Then we have to see the uniocular movements, ductions, and binocular movements, versions. Here I want to stress upon that simultaneously we should see for near point of convergence as well as near point of accommodation with a target of picture or the alphabet, which is brought closer to the patient. And we have to ask whether the child is seeing double and when the child is seeing blurred. The point of blurring is the near point of accommodation, and point of doubling is the near point of convergence. Now we have to see binocular vision. A simple test to see for fusion is Wirth's 4-dot test. Here right glass is put in front of right eye and green in front of left eye. If the patient is seeing 4 dots, fusion is good. If only green dots, then right is suppressed because right eye vision is not there. If he's seeing 5 dots, then there is diplopia. Then we have to see whether it is crossed or uncrossed, like right on right side or right on left side. Cross diplopia is there in uncrossed eyes and uncrossed diplopia is there in crossed eyes. Then we have to see stereopsis. Ren dot test both for near and distance is used. Another test is litmus fly test. This is very simple test to examine stereopsis. Usually, if the stereopsis is more than 400, we can elicit this in a clinic. Examiner holds pencil horizontally in his hand and child is instructed to align it. Previously it was done with vertical, putting it vertically, but monocular clues are there. So we have to better check it keeping in horizontal position. There are certain special tests like diplopia tests if the patient is saying diplopia, 3-step test if in vertical deviations, and AC by A ratio is measured if accommodative component is there. Roughly, if the near deviation is more for near and the difference is more than 10 prism diopters, we have to check the AC by A ratio. Squint evaluation is incomplete without refraction and fundus examination, which was covered by Dr. Kavita. Here I want to stress upon that squint is a very tricky subject. Instead of distracting, just go by methodically and in small steps, and management should be customized based on the patient's needs. Then we will definitely achieve the goal. Thank you.
Thank you, Dr. Rashmi. It was very well covered. Dr. Dedia, do you want to add something what she has told us?
Because basically, I think 8 minutes is very less time to cover this very large topic. I think Dr. Rashmi has covered relevant points very well. So, if there is any specific question, I can answer. Otherwise, if somebody is interested, I have written a CME series on this. They can refer the whole book. That is around 80 pages. So, but she has covered the silent features.
May I ask a question?
Yes, ma'am.
Sir, what is the role of synaptophore nowadays?
It is instrument to be kept in museum.
I can add something on that.
Then how can you see for abnormal retinal correspondence if synaptophore is not there? Is there any method? Because we used to see ARC on synaptophore previously.
Ma'am, basically in the squint, let us talk very practical. Basically, the patient comes for two things. One is for vision and second is for cosmesis. Everything other, nobody is interested in theory. So patient wants cosmesis, patient wants vision. So the first thing is, if there is amblyopia, you correct the amblyopia and improve the vision. And secondly, you correct the squint. And if the deviation is basically more than 50 prism diopters, you have to do the most likely second surgery. So basically, you do the correction accordingly. So these are the two essential things, and I believe in practicality and not any theoretical aspects.
Thank you so much, sir. We welcome Dr. Alay Banker, who has joined, and he will be speaking on our. Sir, Dr. Alay. Now we will go to our third talk, which will be by Dr.
Vinita.
Chaurasia.
Dr. Vinita, can I add one thing to Dr. Kavita's question? Sure. She was asking, how will you test without synaptophore this thing, ARC and normal retinal correspondence? Yeah. So you can use the Bagaloni's striated glasses, or even sometimes with Worth 4-dot test, you can see whether it is NRC or not. But with Bagaloni's striated glasses, you can test ARC.
Okay,
I hope.
Thank you, sir. So our third talk will be important points of amblyopia and newer advances in its management by Dr. Pawan Chaurasia. Dr. Pawan, you can start. Your screen is not visible yet.
Okay, ma'am. I am visible.
Yes, yes, proceed, please.
Okay. Good morning, everybody. Thank you for giving me a very good topic, amblyopia management. So, what are the amblyopia? This is the developmental defect of visual processing in the central visual pathway, leading to the loss of visual acuity in the absence of any identifiable local ophthalmic structural or pathological cause. This is either unilateral or bilateral. In Hindi or in the term of patient wording, this is a lazy eye. So, what are the requirement of normal visual development? First, to see the clear retinal image, equal image clarity in both eye, and proper alignment of both. So, what are the salient feature of amblyopia or lazy eye? Abnormal contour interaction, reduced contrast sensitivity, positional uncertainty, spatial distortion, poor accommodation, abnormal eye movements, suppression and impaired binocularity. So, what are the classification of amblyopia? Is everybody know? Strabismus amblyopia, suppression or pattern distortion amblyopia is refractive type anisometropia, and media opacity due to unilateral cataract, corneal opacity, and some other pathology. And bilateral pattern distortions like emetropia or media opacity in both eye. So, what are the management of amblyopia? So, first you clear retinal image by prescribing the glass hypermetropia, hypermetropia, myopia, or in cases of astigmatism. If any pathology, first you correct the pathology, then correct ocular domination in the terms of patching therapy, penalization with drop, penalization with plain lens in normal eye, and Vanguard filter. So, coming to the amblyopia treatment studies, this is the first PEDIC group, Pediatric Eye Disease Investigator Group. They include the randomized control trial ATS 1 to ATS 18. So, what are the Pediatric Disease Eye Investigator Group? Before the ATS, what are the treatment modality for amblyopia treatment? First is patching therapy. When to start patching therapy? Time was the essence. So, according to the grading of the amblyopia, mild, moderate, and severe. So, in moderate amblyopia, more the better. More than 5 to 6 hours per day, patching therapy is prescribed. For the severe amblyopia, they prescribe full time or mostly waking hours. They prescribe patching therapy for full time or जब तक कि बच्चा जाग रहा है, most of the waking time. If the patching therapy is fail, and in moderate amblyopia, all they prescribe penalization in the form of atropine treatment. So they include the maximum age group for amblyopia is 6 to 9 years before the ATS trial. After the ATS trial, treatment modality is changed. They first line of treatment for the amblyopia, optical treatment, then patching therapy with atropinization or penalization, and Vanguard filter. So they prescribe the guidelines. For the first, you correct the refractive error. If the patient is hypermetropic anisometropia more than by 1.5 diopter. In myopia cases, more than -3. In astigmatism, plus 1.5. Bilateral hypermetropia more than 5. And bilateral astigmatism more than 2.5 diopter. So they categorize the amblyopia depending on the visual assessment, mild, moderate amblyopia, and severe amblyopia. So two ATS study have evaluated the effectiveness of optical correction alone, and they found visual acuity improvement approximately in 3 lines in the case of moderate and severe amblyopia cases. They found resolution occurred in 25 to 33% of the cases. And they first start with the refractive correction alone and follow up every 6 to 8 weeks till improvement in the amblyopic eye. So they need additional amblyopia treatment in better amblyopic eye, less treatment burden for the better compliance. So they include optical correction with high hypermetropia, more than 4 diopter, and in cases of astigmatism, more than 2 diopter, and found improvement in core line. 74% patient achieve visual acuity more than 20/25 or much better. So what are the treatment, additional treatment with the refractive correction? If the patient do not respond to refractive correction alone or visual acuity cease to improve. So part-time patching versus full-time, atropine penalization and Bangert filters. So what are the patching doses according to the age? Age 3 to 7 year, 3 to 7 year. They compare both 2 hour versus 6 hour of daily patching. So in the cases of moderate amblyopia, they suggest part-time patching, and in cases of severe amblyopia, more than 6 hour, minimum 6 hour patching therapy. So full-time patching is not always needed because the compliance is very poor in cases of initial treatment. So part-time patching have better compliance and they found equal results. But in some cases, in severe amblyopia, they also respond 2 hour patching more because the compliance is better in part-time patching therapy. So atropine versus patching therapy in the cases of moderate amblyopia. Daily administration of 1 drop 1% more than 6 hour daily in the cases of moderate amblyopia, and they found equal improvement in amblyopic eye. But the visual improvement was slower with atropine penalization. They also conclude that weekend versus daily atropine in the cases of moderate amblyopia in the age group of 3 to 7 years. So they found amblyopic eye visual acuity improvement was similar in the both groups at a follow-up of 4 months. So historically, atropine was reserved for moderate amblyopia cases in the children 3 to 7 years, and they found that visual acuity improvement is 4.5 to 5 lines. But the disadvantage of atropine is they reverse amblyopia observed in few children, and atropine side effect mostly in cases of also found atropine side effect like dryness, flushing of skin, and in some cases mental confusion or disorientation of the patient. So in the cases of neurological symptoms or neurological disorder, we use 5% home atropine. Can we substitute for atropine for the side effect of replace the side effect of atropine? So there are another form of treatment is Bangert filter treatment. This is a translucent filter and full time bearer. डिफरेंट डेंसिटी फिल्टर्स होते हैं जो डिफरेंट डिग्री ऑफ इमेज को डिफोकस करते हैं. सो फुल टाइम बियर ऑफ बैंगर्ड फिल्टर प्रोवाइडेड विजुअल एक्यूटी इंप्रूवमेंट 1.8 lines, similar to 2 hour daily patching therapy in the case of 2.3 lines. So this is better for fewer adverse effect and better compliance for the patient. So this is the first line treatment when the patient is poor compliance for the patching therapy or atropine therapy. What are the disadvantage? अब disadvantage, this is the peaking around the filter. Patient इधर उधर से भी दे सकता है. So the amount of degradation with filter tend to decrease over the time. This is the disadvantage of Bangert filter. So what are the residual amblyopia? In cases of residual amblyopia, 3 to 8 years, first verify compliance, then repeating the cycloplegic reflection and re-examine the ocular structure. इंक्रीजिंग पैचिंग टाइम, हो सकता है कि पेशेंट कंप्लायंस पुअर हो पैचिंग थेरेपी के लिए या फिर पैचिंग थेरेपी को रिस्पॉन्ड नहीं कर रहा हो, तो इंक्रीज द पैचिंग टाइम फ्रॉम 2 आवर to 6 hours. And and in older children also included adding oral medications. This is the newer treatment for amblyopia. So in case of what are the recurrence of amblyopia? Recurrence was defined as loss of more than 2 lines in the amblyopic eye. So in the age group of 3 to 7 years, approximately 25% experience the recurrence during the first year of treatment. Same with patching or same with atropine ointment. So all and in the age group of 7 to 13 years, only 7%. Most of the recurrence is found in less than 3 to 7 year of age group. So this is the historical diagnosis. First, before the ATS, patching therapy is main treatment, first line treatment, and current is optical refractive correction. So this is the treatment modality change after the ATS trial. So what are the pharmacological adding therapies? This is not replacing the optical correction or patching therapy or penalization. They are additive advantage with the amblyopia. Levodopa, carbidopa combination therapy, fluoxetine drugs, GABA antagonist, and citicoline. This is the newer modality of binocular therapy or dioptic therapy. But according to the British Medical Journal, they are not replacing or they are inferior to the optical correction or patching therapy. Optical correction and patching therapy with penalization, this is the standard method for treatment of amblyopia. They also binocular therapy and dioptic therapy. Some of the newer modality of treatment prescribed with the help of binocular games in the iPad games. Liquid crystalline display glasses, this is used for the intermittent occlusion therapy in the cases of intermittent exotropia or esotropia. This is the newer treatment in the form of amblyopia therapy. But they are suggesting the first line treatment is optical correction, then you can give a patching therapy and in the form of penalization therapy. So this is the recent advantage with the patient. Levodopa, carbidopa, GABA antagonist, and citicoline. They are using very much in the form of citicoline.
Dr. Pawan, can you sum up, please?
Ji. So this is the flow chart with the, for the treatment of amblyopia. So first you diagnose the amblyopia. To diagnose the amblyopia and treat refractive error. If the patient recovering, improving in 6 to 8 weeks, continue spectacle and follow up. And no improvement, then you can use atropine. And if the patient is improving, this is the actual flow chart for the management of amblyopia. Thank you, ma'am.
Thank you, Dr. Pawan. Thank you so much. Dr. Shashikant, what is your take home for part-time occlusion or a full-time occlusion? What do you prefer, sir? Dr. Shashikant? You can answer. What's your take home? Whether you part-time or
if it is a moderate amblyopia and the vision is better than 618, then we usually prefer 2 hours patching, and then we slowly switch over to, if the vision is not improving, then we switch over to 6 hours of patching. And if the vision is very poor, like 636, 624, so those patients, we usually start with 2 hours patching, we let the vision little bit improve, and then give full hours of patching. But we give suppose the vision doesn't improve even with the part-time patching, then we give a trial of full-time patching, because if you initially start with full-time patching, sometimes the patient may not be very cooperative. So initially get them used to the 2 hours patching and then switch over to full-time patching.
Yes.
And if the child is very compliant with full-time patching, and we do for patching for 3 months, and even if that patient doesn't improve, then we think that patient may not improve. Even if the patient was compliant, wore glasses regularly, did the proper patching, and if the vision doesn't improve, then most of the time we will go back and again do maybe OCT, look for an occult macular dystrophy. Some things we might miss, and then and if everything is normal, and then we switch, then we stop the patching.
Okay, Dr. Sumita, what is the end point for stopping the patching?
I would probably, I will diverge with Dr. Shetty here slightly, because I do believe that compliance is better with part-time patching. And in my experience, 3 months is a very short time. Sometimes parents don't report exactly how much they are patching. So at least 6 months to 8-9 months, I would give a trial before I say, okay, taper it down. And yes, first your diagnosis of amblyopia should be sure, because -3 myopia and 6/18 vision just doesn't collaborate. That's not amblyopia. That's something else. So your diagnosis of amblyopia should have a real reason that there is amblyopia. And I think part-time patching is as effective as at least moderate to mild to moderate amblyopias do very well with part-time patching. Compliance is good. You can show improvement. And one trick here is that you should always check the near vision also, because a lot of us do tend to not check it for children. And near vision improvement is often much faster than the distance vision improvement. And you should also look at the speed of reading, because these are the things which you have to tell the parents next, say 6 weeks later when you're calling them, they are happy, more ready to comply. Second, you should say how he is reading. Look at the speed of reading and it improves. So these are small tricks which you can kind of motivate them to do better with compliance and to stick to your patching. Because if you say no improvement, they tend to go for a second opinion, which is not. If it's a severe amblyopia, child is 8 already, in first follow-up, you may or may not see any improvement in distance vision. I think to motivate the parents to say, yes, child is doing better. Vision is a very, very important criteria there. You should use telling the parents ki, see, they often notice it, how haltingly child read the 689 earlier and now he is more fluent in it. So these are small things which you should do. And I think 3 months is a very short period for you to decide for lifetime in an 8-year-old child ki there will be no more improvement. Similarly, the older children also deserve a trial of patching if it has never been given before. And you should always see, you should always give a trial of glasses and patching. One common mistake which I see a lot of general ophthalmologists do, they will check the PMT and child will read 3/60 plus 5 also 3/60. They will not give glasses. I think that should be avoided. Correct refraction should be given, even if it does not show any improvement in vision. You should always correct it fully and then start patching, and then tell the parents right ahead, you may not see improvement in 6 weeks, but still I'm going to see you. You will see improvement in the near vision. You will see improvement.
Sally wants to say something.
Small tricks you should probably do.
Yes, exactly. Dr. Jethani, you want to say something?
Yeah, I just want to add to what Sumita madam said. I completely agree with her. The problem is that general ophthalmologists feel that patient will have diplopia. Patient is not going to have diplopia. Patient is already in amblyopic suppression. He is not going to have diplopia. Full correction has to be given. That is a very common mistake which is there. If one eye is having +1, other eye is having +5, they would undercorrect it to +3 because he is not improving. It is PMT, so they would give +3. You should always give full correction, because if there is anisometropia in the eyes, the child is going to accommodate similarly in both the eyes. He's not going to see clear in that eye, even under binocular conditions. Even when we see that, when we say that patient is having suppression, still patient will be using that eye. So he would not have diplopia. That is, I mean, that will not be there. That is the common, ground which they hold, that patient will have diplopia. Patient would never have diplopia. I just wanted to add few things in ambulatory treatment. I think because of the newer treatments, it has become the pediatric ophthalmology.
भैया तीन चीजें और रख देना कि महंगी
What
है
has
ये
happened is that now we can
400-500 रुपए का ये एक्चुअल पाउडर नहीं
4 hours at the
उसने ले लिए पैसे दे दिए
do dichotic exercises. So what we do in an isometropic ambulance is that we do
वो दे
tell them
दिए
to patch.
वो
We do
मेडिसिन
tell
दे
them
दी
to patch, but at the same time we also tell
पैसे
them
दे दिए उसने
that they can add on to doing diplopia, dioptic stimulation. So we use
अरे 16,000 पहले कैसे लेके ऐसे कैसे
पूरा टोटल जो है वो लमसम बताया था हमको।
अरे विनीता, आज डॉक्टर ललित तो
I am telling, but he's not. Dr. Lalit, please.
अरे तो कंसेशन नहीं दिया उसने
अरे दिया होगा तो सोना ही है।
Raman, can you mute Dr. Lalit, please?
आपके नाम से रिकॉर्ड
You can mute all of us.
Raman,
Actually,
somebody
we'll
from
mute one
the
by one.
company can mute. Dr. Jiten Jethani.
Yeah. So
Dr. Jethani.
yes, ma'am. I was just saying that with newer treatments, the good thing is that we can do a lot of things together also. There is no such thing that we just have to patch the patient, wait for the child to not improve and then give dioptic exercises. Dioptic exercises is a wonderful way of supplementing patching. So I do use it a lot with anisometropic, especially in anisometropic amblyopia. And even for recurrence of amblyopia, once the patient has improved with patching, we tell them to do dioptic exercises. Once we remove them out of patching, we just tell them to do dioptic exercise. I think with dioptic exercise, it's a wonderful tool to even develop binocular vision. So it has got a good place where we can use two things together. And often what happens is that children become very fed up of patch very easily. So if they have something else to hang on, they keep on doing multiple things.
Thank you. Thank you, Dr. Jethani. And I will request all the participants muted. Sir, please.
Can I ask one question?
Sir, please.
What is the highest age? What is the oldest age of the child where we can give a trial of amblyopia to any one of the panelists?
Yes, Dr. Sumita, please.
I will quote from the evidence. If you have around, if you look at what has been studied, up to 17 years has been given trial of patching. But there is a little rider there. I'm quoting IATA study here. Rider is that there should not be any previous failed patching attempts. So if the child has never worn glasses, has never been patched, or has compliance with the previous patching has been very poor, it's worthwhile to give a trial of glasses, contact lenses, and patching to as old as child, up to 18.
And an isometrop amblyopia.
Yeah, a lot of them will improve by a couple of lines. I'm talking about, again, I don't mean deprivation amblyopia here.
Yes.
Deprivation at this age will not improve. So if you have had a cataract, he's not going to improve. If you have had a ptosis, he's not going to improve. But if it is an isometropic and strabismic, chances are that you will improve a vision slightly.
Any difference with the hypermetrop or myopic patient?
Yes, you can. You can.
Because in few of my patients, I have tried myopic anisometry at age of 23, and she improved from 636 to 69.
I'm not surprised. A lot of times the glasses have never been given.
Yeah.
Sometimes they improve just with glasses, leave alone patching. They will improve.
No, with even with correction, she was 636, 624 partial.
Yeah.
With amblyopia, with occlusion, she improved to 69.
Yes. It is
hypermetrop 17, 18 years old I have seen. So that is the reason.
Even with refractive surgery also they improve.
Kind of dramatic improvement with hypermetropes, but myopes sometimes very, very gratifying results even at older age. So But important thing is that what I say is does not hold for deprivation. Deprivation is
No, it doesn't.
hard cookie too.
Sure. So we should proceed further now to overview of infantile esotropia by Dr. Jiten Jethani. Dr. Jethani, please.
Okay, madam. I will share the screen.
And I will request all other participants to please keep them muted.
Ma'am, Dr. Ganesh talk will be taking it after Sir's talk.
Dr. Ganesh talk is at late. I think
Okay.
management pearls of pediatric cataract is 7th number.
Done, ma'am. Done.
Am I audible?
Yes.
Okay.
Yes, Dr. Jitin, you are very well seen and visible and audible.
I will be speaking.
Audible, visible.
Yes, ma'am. So many thanks to Vinita madam and Bhopal Divisional Ophthalmic Society for giving me the opportunity to speak. Just a minute. Sorry. Okay. So sorry for the interruption, but the battery was low and the computer would have switched off. I would be speaking mainly on the subtype of a very small subtype of esotropia. This is the broader classification just to get the perspective that we are talking about a non-accommodative committant esotropia. And in the non-accommodative esotropia, we are talking just about infantile esotropia. So most of the things which I would be speaking would be purely with a non-accommodative esotropia, considering that refraction has been done. In infantile esotropia, you may have hypermetropic or myopic refraction, but you have to give glasses and then we have to progress. So any case of strabismus, we have to do a cycloplegic reflection, as has been discussed before. So what exactly is essential infantile esotropia? And this is not congenital esotropia. A lot of times we do see people still writing congenital esotropia. The word congenital has almost been removed from essential infantile esotropia. The manifest deviation may be there after birth till 6 months of age, and after 6 months it is referred to as early acquired esotropia. Prevalence is 1%, that is from US population, not from Indian population. Unfortunately, we don't really have robust Indian studies for incidence of strabismus. So consistent findings in infantile esotropia are onset from before 6 months of age. There would be a large angle and this would be mainly stable. So you would see that patient would come in follow-ups and the angle would remain stable or it may slightly increase. There may be initial cross fixation, initial alternation, and later if we don't do anything, patient may end up into taking up preference of fixation in one of the eyes. There should not be any apparent CNS involvement. So children with delayed development should not be clubbed into essential infantile esotropia. The classification or the findings itself, the name essential infantile esotropia means that there should not be an apparent CNS involvement. Cortical visual impairment, periventricular leukomalacia, delayed development, delayed visual maturation, these are separate subheads and they do not fall into essential infantile esotropia. A very important finding is asymmetrical optokinetic nystagmus. And these are variable findings, variable because they may be present, they may not be present. Amblyopia may be present if you see them late or if they stop alternating, apparent defective abduction. Now, because of the large angle, what happens is there is alternate fixing with the eye, and this may lead to an apparent defective abduction. But if you close one of the eyes, they would have a normal abduction. And that is how you differentiate them from the congenital lateral rectus palsy or Duane's retraction syndrome. There may be an associated A or V pattern, an associated infraoblique or a supraoblique overreaction, an associated dissociated vertical deviation, dissociated horizontal deviation, or dissociated torsional deviation. This would occur at a later date. So normally a DVD will not be there when the child presents at 9 months of age or 8 months of age, but this would present later at 1.5 or 2 years of age. There may be an anomalous head posture, as we see in infantile esotropia with CNCS syndrome, manifest latent nystagmus as in CNCS syndrome, and it may be hereditarily acquired. Now, So what you would be seeing basically is that there will be a nasally directed drift of the non-fixating eye, and there will be a fast corrective phase. The fixing eye would be towards the covered eye. Now, this has to be differentiated from nystagmus blockage syndrome, and it could be differentiated only on the basis of electronystagmogram. Otherwise, it would be very difficult because both the patients would be having ESO and nystagmus. Nystagmus blockage syndrome will block the nystagmus in esotropia, and in other times, the eyes would be straight and there won't be any esotropia, whereas CNCS syndrome patients would essentially have esotropia as a primary condition. When you differentiate it on the electronystagmogram, you will see decreasing slow phases, decreasing velocity in the slow phases. Whereas in the nystagmus blockage syndrome, the velocity of slow phase would exponentially increase. Now, what is optokinetic nystagmus asymmetry or OKN asymmetry? In normal subjects, when you elicit an OKN response, what happens is there is a slow phase, it moves along with the drum, and then there is a corrective fast second. In infantile esotropia, when you show them from nasal to temporal side, it is difficult to elicit this. And this is known as optokinetic nystagmus OKN asymmetry. Now, this does not show that it is infantile esotropia, but it shows that the deficit has occurred at a very early age, and it represents the state of immaturity of the binocular visual input. You can even see this in Duane's retraction syndrome. So it is a consequence of infantile esotropia, but it is very consistent with essential infantile esotropia. A small word on why exactly does infantile esotropia occurs. There is no fixed theory. This was the latest article by Dr. Brodsky from Minnesota. Now, what he says is that the OKN asymmetry persists throughout the life. This occurs from the subcortical visual system, and so he believes that this could be basically the subcortical visual system which has turned normal in normal children, but retains its function in the children with infantile esotropia. Just a short word about that. We come to the important aspect, as Dr. Redia said, that we are basically concerned with vision and cosmesis part of the strabismus. So the goals of the treatment obviously become the same as he said: good alignment in all gazes, orthotropia to a small esotropia. A wonderful article, a very old article by Dr. Kushner way back in '96 was published in Archives, where he said that an angle less than 6 prism base out is desirable. Orthotropia, of course, is the best outcome, but if there is a small residual esotropia, it should be less than 8 prisms. And I read another paper by Dr. Pradeep Sharma where he said that if your angle is less than 4 prism diopters, there's a good chance that you can develop binocular vision. This was presented in All India, I think, and later got published. So second part of goal of treatment is that binocularity should develop. There was a question on ARC. We will be seeing a little bit on that. And another article by Dr. Kushner which says that binocular visual field expansion occurs post-surgery, even in adults. So even in adults, if you are operating essential infantile esotropia, there would be some improvement of binocular visual field, if not binocular vision. So these are some of the findings of microtropia, which is the end point of essential infantile esotropia surgery. Primary microtropia we won't see, but secondary microtropia is what is desirable outcome in essential infantile esotropia post-surgery. So these are some of the findings in secondary microtropia. And obviously, if you have a secondary microtropia, it is not normal retinal correspondence. It is obviously an abnormal retinal correspondence. So non-surgical treatment, there is not much in essential infantile esotropia in terms of non-surgical treatment, except for glasses and cycloplegic refraction, patching for amblyopia. Prisms are not very useful because the angle is too large, and so we move to the surgical treatment. Now, broadly, there are two controversies or two fightbacks or two groups regarding timing of the surgery. But I think most of the studies now have a conclusive evidence. Even the Cochrane has a database which suggests that surgery should be as early as possible. Now, they have suggested people operating at 7 months and 8 months also. We at our clinic do not operate before 9 months, mainly because we want to see that findings should be consistent at least 2 visits. And we want to check the refraction at least twice to be sure that we are not missing out on anything. Type of surgery, I think it has been settled down now that bimedial recession is the preferred way, but unilateral recession resections are also done with or without infraoblique recession, depending on whether there is a associated infraoblique overaction, there is an associated bilateral superoblique palsy or not. You have to be prepared that dissociated deviations may occur even if you correct the strabismus part at 9 months or 10 months of age. Now, this I have taken from an article which was published in Current Opinion 2015, which they did a meta-analysis of all the papers which have been published till 2015, and they suggested that early surgical intervention for infantile esotropia leads to a likelihood of development of binocular vision. Apart from that, botulinum toxin, we will take a separate slide on that. And the best surgical procedure, there are no head-to-head comparisons between bimedial recession and unilateral recession or resection. So we come to my last slide, and what chemodenervation has also taken a lot of, there are a lot of people who are interested whether once you give botulinum toxin, there's a good chance that children may develop binocular vision. Their eyes may become straight at 6 or 8 months of age, and they may not need another procedure. So this is a Cochrane database. They found out that chemodenervation was not better than the surgery part. And this was another paper recently published which suggested that the mean pre-injection deviation was almost 38 PD, and they suggested that the success rate was around 76%. But the success rate was in terms of the success rate was in terms of the fact that whether the eyes became straight or not, and not about whether they required another procedure or not. So chemodenervation is definitely safe, can be done, but at this point of time, it is not superior to strabismus surgery. So basically, the point is that even if you do a strabismus surgery, you may still require a second procedure. And that is where they say that chemodenervation you can give at a younger age, and maybe you can operate later if it is not successful. So we will put chemodenervation at that point. Thank you so much. Thank you again.
Thank you, Dr. Jethani. What is the minimum age you have operated?
As I said, I have not operated under 9 months of age. We don't go for that because first of all, children don't present that early. Now the patient whom we operated, he was a child of a doctor, so they agreed to get surgery done at 9 months. The parents were pediatricians, so it was easier to convince them that this is required. The child is now almost 6 years of age, doing well, has binocularity. But I think younger than 9 months will be a little too much from my point of view. Not that people are not doing it or not that people have not published it, but we generally do not go beyond 9 months because we have to be sure that the child is indeed having a stable angle. Because once you operate, you should have a stable angle. You should be operating for a particular angle, and you have to do at least refraction a couple of times to be sure that you are not missing out on anything.
Okay, and what is the preferred method of doing the surgery?
I think.
Yes, Dedia sir.
I think Dr. Jethani, in these sort of patients, the essential criteria is these have either minimal or low refractive error.
Yeah.
These sort of patients, that is one of the essential criteria to diagnose these sort of patients. And the pertinent question is how early to do the surgery in this sort of infantile esotropes, because there are various reports, but they say basically preferably it should be operated before 1 year of age, and it should not be delayed beyond 2 years of age. That most of the literature suggests. And regarding the surgery, I think it is individual surgical choice whether you do bimedial recession or you do resection procedure. The results are equivocal in most of the series. And one other important point is most of these patients, they require on an average around 2.5 surgery. So that must be explained to the parents.
Because most of the time it is very large angle, so I think we have to do resection both. What's your take?
I think that is very individual choice. So I think you can do bimedial recessions, and you can do unilateral resection and then do other eye, or you can do resection and medial rectus recession in one of the eyes. So that depends on the angle, and it is very, very individual.
Yeah, there are reports. There are reports for both.
Yeah. There are plenty of references, but there is no head-to-head trial. I mean, because the person who does bimedial recession doesn't do recession resections, and the person who does recession resections doesn't want to do bio. So there are no RCTs because squint is squint works very well in your own numbers and in your own hands. So you may.
Hello.
We are not able to hear the audio.
Sir, you can comment. I think Dr. Jethani audio is freezed.
Yeah.
Now we can hear you.
I think what I was saying was that strabismus surgery appears to be similar, but it is not similar in everybody's hands. Everybody has different measurements, mainly because somebody will measure from the posterior part of the insertion, somebody would measure from the anterior part of the insertion, somebody would put very tight sutures, somebody will take full thickness sutures. So it depends. It is very variable. I mean, somebody would leave a 1 millimeter stump, and other person would say that this is a 1 millimeter resection. So it is very, very, very subjective. My 5 millimeter recession, maybe somebody else's 4.5 and somebody else's 6 millimeter. So that is the reason why it becomes very variable in each person's hand. So if there is a RCT by a person who does bimedial recession and does recession resection, we can be convinced that this particular procedure works well. And second point is that if it is working well for you, why change it? I mean, mainly, Dr. Dedia he said that there are more than 2 procedures required is basically because children may develop DVD at the age of 1.5 to 2 years of age. So that also has to be taken into consideration. They do come back and they do complain. And it is true that in institute, you can tell them that these are the riders. In private practice, it is very difficult to tell them that these are the riders, because then they feel that, you yourself are confused. As a doctor, you don't know how many surgeries it would take. So you can inform them, but you can't tell them that short he will develop DVD and he would require another surgery. So those are practical things. They are not. What he said is absolutely right. There's no doubt about it.
Sure.
Well said. Well said. Agreed.
Thank you so much. Now we move on to another topic, which is very important, is the Duane's retraction syndrome. Take home points by Dr. Sumita Agar. Dr. Sumita, are you there?
1 minute.
Yes.
Is it visible?
No, not yet.
Not yet. Okay, 1 second. Is the chair visible?
Yes, it's visible and you are audible too.
Okay. Good afternoon. Classical triad of motility deficit, strabismus, which can be esotropia, exotropia, or orthotropia also. You may have other things like palpable fissure changes, and post-action tests are often positive for medial rectus or lateral rectus or both. And as I said, other variable features which are compensatory mechanisms include anomalous head postures, sometimes upshoots and downshoots, which are actually a sequelae of disinnervation and fibrosis, which happens with disinnervation. And it can be variable, and it can be all can be present in a patient, some can be present, or only one or two things may be present in every patient. And of course, it may have systemic associations which need to be looked for. So this is a typical patient with a, if you can see in this picture, he has a left face turn and he has a left duens, where you can see a slight narrowing, not very dramatic palpebral fissure changes, but here abduction limitation, nearly straight looking eyes, and has a small esotropia in the left eye if you see carefully. This patient also has duens, but you can see a large exotropia, adduction limitation, probably a upshoot on attempted adduction, but not so much of dramatic abduction limitation and not so much of a palpebral fissure changes. So each patient of duens is completely different and a unique entity by itself. This is a child with Duane syndrome, in bilateral Duane syndrome. Again, he nearly appears straight or probably has a small esotropia, but dramatic palpebral fissure changes and abduction limitation. Another patient who has orthotropic Duane's, and you can see in the left eye there are palpebral fissure changes, but hardly any angles or almost orthotropic in the primary gaze. Then you can have associated findings like this patient has severe retraction and upshoot. When she attempts to adduct here, eye almost disappears under lid. You can have systemic associations like golden heart. As you can see, this child has a ear tag and slightly dysmorphic features. Another one with Kippel-Feel anomaly. Another one with, again, here you have choriostomas and dermoids. So all these can be, and you should look for them. And especially if children may come to you with dermoid, look for Duane's also. It goes both ways. Hearing deficits is very common. So you should probably, these are the things which you should ask for. And as ophthalmologist, when you know about the association, you should probably ask guided questions regarding these things. So what can mimic Duane syndrome? The commonest mistake is lateral rectus paresis, which can happen, but congenital lateral rectus paresis is very, very uncommon. So in a child, if you see abduction deficit, it's more likely to be Duane's rather than lateral rectus paresis. Infantile esotropia can sometimes mimic Duane syndrome in terms of apparent abduction limitation. Mobius syndrome also can mimic Duane syndrome. So a trick to look for differentiate between lateral rectus palsy is to look at the primary angle deviation. The child down here has Duane syndrome. You can see their abduction deficit is more or less same, but look at the primary angle deviation in the patient with lateral rectus palsy and with Duane's. Nearly straight looking eyes with abduction deficit, large angle esotropia with abduction deficit, probably 6th nerve palsy. Now, why these patients may come and seek your help? You can have patients presenting with strabismus, both ESO, exo, ortho is known. Anomalous head postures, mostly head turns. It can be on the same side or it can be upon the other side, depending on how the innervation is and what is the primary angle deviation. You can have patients coming for cosmetically unacceptable upshoots. The picture I showed, that girl came to me because of the upshoot, because it's such a severe upshoot. You can have sometimes patients reporting with diplopia and side gazes due to the motility limitation. It can be very, very disturbing when you are driving. And these are the things which patient may ask you to do something about. But you should know when to do nothing. Don't do anything in Duane's, because in Duane's or a lot of strabismus, actually less is always more. So if it's a very small angle strabismus with no anomalous head posture, you should probably not touch those patients. Again, patients who have unrealistic expectations like that after surgery, their motility will become normal and everything will disappear, probably it's time to give them a reality check and leave the decision to them rather than pushing surgery at them. So what can be definitely made better, if not cured? Yes, you can definitely, strabismus can be made better. Anomalous head posture can be corrected to a certain extent. Significant upshoots and downshoot can be minimized. And motility, certain extent, can be improved, though not completely normalized, but it can be made a little bit better. So what are your options surgically? Again, I don't want to put a slide there, but probably a lot of these children don't think that just because they have abnormal head posture, they may not have diplopia, they may not have amblyopia. Anisometropia is fairly common, and you should probably do the right thing by doing cycloplegic refraction vision checking and all these patients also, like any other patient you would do. So strabismus is very commonly associated, and often that is the driving force towards the head posture, though there can be other things like upshoots or sometimes severe retraction. They can also drive the head posture, but it's almost always it's the strabismus, and surgery can help in these patients. So look, in fact, now the classification, that Huber's classification, which we read in textbooks, probably good for passing exams. But when you're a clinician dealing with these patients, it's probably better to classify them as esotropic or exotropic or orthotropic duens. And I think it's more accepted also now. So if you look at esotropic duens, means where there is a esotropia in the primary gaze, usually surgical correction is required unless, as I said, it's a very small angle and no head posture. So medial rectus recession is the procedure of choice. It can be both unilateral or bilateral depending on the angle. And up to 20 prisms, you can get away with a one eye medial rectus, especially the ipsilateral eye. But if it is more than 20, then you need usually bilateral medial rectus recession. And you can definitely make it a little bit asymmetrical, means you do more medial rectus recession in unaffected eye to induce fixation duress and also to match the motility deficit. Sometimes you can operate on a very large recession in the other eye also to match the duction deficit in selected patients, again, where there is, and not operate on duens eye at all. But it's probably safer to do, you will not go wrong by operating on the eye with duens compared to the eye not having duens. Now surgery here will improve both head posture and strabismus, but may not. This surgery, medial rectus recession, will not improve motility greatly. Again, bilateral DRS may require bilateral surgery, and even if it is bilateral, sometimes it may be asymmetrical and you may have to do asymmetrical surgery or recession. So this is one patient, as you can see, isoduans with a head posture, and we did by asymmetrical bimedial recession, and motility, as you can see, is not greatly improved, but head posture is better, iso is better, and patient was quite happy. Exotropic duans is relatively less common compared to esotropic, but this is more difficult to treat, and it is as it is more often associated with disinnervation sequelae like upshoots, retraction, and other problems, having very tight recti. And here again, lateral rectus recession is probably procedure of choice. And usually larger recessions are required. Again, if the angles are very large, more than 20-25, you may have to go and do the other eye also. If it is associated with very severe co-contraction, retraction, then, or there is severe disinnervation of the lateral rectus, then you may have to actually kind of disable the lateral rectus. And because it's the innervation to the lateral rectus which drives almost every abnormality in Duane syndrome. So sometimes it is good to completely take lateral rectus off the globe to take care of the innervational issues. And periosteal fixation has been done. Very large recession, like 12 to 18 millimeters, have also been done in conditions where there is a exotropia with a very severe co-contraction and retraction. And of course, lateral rectus recession can be combined with other procedures, like if patient has a significant upshoot, which is more likely to happen in exotropic duens, you may have to combine it with a Y-split along with recession, or you may have to do a medial rectus recession to take care of severe retraction if it is associated in exotropic duens. Now, if patient has only upshoots and downshoots, it is usually due to the tight fibrotic lateral rectus, which produces a leash effect and allows the globe to slip up or down. And sometimes this can be, sorry, this is spelling mistake there, it is innervational. Sometimes the upshoots can be innervational, and sometimes true inferior oblique overactions can also coexist. So it is good to differentiate between innervational and tight lateral rectus producing the upshoot, And yes, if it is fibrotic tight lateral rectus, then you have to tackle it with lateral rectus recession, Y splitting of the lateral rectus, which has to be accompanied with usually with a small recession. And this will make it better. Like this child who you can see has a head turn, and she was orthotropic or a small ESO in the primary gaze, but has a really disturbing upshoot which parents wanted it corrected. So here I just did a lateral rectus recession with a little Y split, and as you can see, she head posture is better, upshoot is much better compared to her pre-op here. And basically, Y splitting usually involves splitting the lateral rectus up to 10 to 15 millimeters from the limbus, from the insertion, and you can put one half on the upper half, and you can split it like a Y here. The distance between the two limbs of this Y should be at least 10 to 12 millimeters. Some people say it should be even larger than that to be really effective. This prevents the glove from slipping under the tight muscle, and this usually will make upshoot better. If there is severe retraction, again, it is usually related to very tight lateral rectus as well as very severe misfiring of the lateral rectus during adduction. And this probably you need to require recession of both the recti. It can be graded, or it can be, depending on the primary angle strabismus, that you can modify the surgery a bit. Posterior fixation suture on lateral rectus has also been described to take care of severe retraction, but I have personally very little experience with this procedure. A large lateral rectus recession and periosteal fixation of lateral rectus also gives good results. Now comes to the motility limitation. Some patients may come to you to address the motility limitation. Again, it's important to give realistic picture to the patient before you operate for surgery. Several options are available nowadays. It can be combined, surgery for motility limitation can be combined with other procedures. Both full tendon vertical rectus transposition as well as half tendon transposition with or without improves motility. Nowadays, recently, from last 5 years, superior rectus only transposing superior rectus has been found equally effective, and it can reduce the risk of anterior segment ischemia where you are not operating on all three recti. It improves motility as well as it also improves the esotropia. Sometimes, if there is not much of retraction or much of co-contraction, then SRT alone without medial rectus can take care of small angle esotropia as well as motility limitation. If the angles are slightly larger, you may combine a SRT with medial rectus recession. Dr. Hunter has reported that SRT, if you do it with medial rectus recession, then the amount of magnitude of MR surgery certainly reduces with SRT. And of course, as you're operating only on superior rectus and medial rectus, the risk of anterior segment ischemia is very low. And you must remember, all the procedures, all the transposition procedures, anywhere, in any condition, always carry a small risk of inducing a new vertical strabismus or torsional diplopia, and this should be discussed with patient before doing surgery. And if you do find a vertical strabismus or diplopia, you should probably be prepared to take the patient back to OR very quickly. So this is a non-augmented VRT diagram where you have just put parallel to the lateral rectus, both superior and inferior rectus. And sometimes you can do augmented where you have put a muscle union or you have passed it through the sclera to augment it further. So there you pass a suture between the bellies of both, say, superior and lateral rectus, as well as pass it through the sclera. And same thing with the inferior rectus. Here, as you can see, only the belly, the muscle tendon has been placed adjacent to the lateral rectus without passing a suture through the muscle or through sclera. You can do a Hamilton partial tendon transposition also, probably will work. So to carry home, Duane syndrome is a very, very easy clinical diagnosis. No investigations are required. Surgical plan has to be customized depending on angle of deviation in the primary gaze, how tight lateral rectus is, how much importance to give the associations like upshoot and this, and how bad are the sequelae of disinnervation. Your surgical plan should include all these things as far as possible in the single surgery. Important to note that I may have given you some pointers about what to do for each cases, but one size does not fit all, and everything has to be customized according to patient's needs and what you see in your examination. And it's always good to have an honest conversation with patients and parents when you do surgery about what you can do or what you can make better. I wouldn't say cure, I would say make it better, and what probably he has to live with. Thank you for your attention.
Thank you, Dr. Sumita, for such a wonderful, crystal clear and crisp presentation. Anybody else wants to add something?
I think Dr. Sumita has Sumita's presentation has covered all the relevant points, but one thing is we must tell that this resection of lateral rectus is absolutely contraindicated in Duane's retraction syndrome. That point must be stressed. And secondly, basically most of the parents they don't like the surgery in normal eye, so that is a challenge.
Dr. Subhash.
Yes, sir.
I want to know your opinion and about Duane's 4, simultaneous abduction. Do you have any experience of this?
No, sir.
Dr. Jethani, Dr. Sunita?
Yes, I have seen few cases where because of very, very tight and co-contracting, when the patient tries to adapt, it suddenly goes for what we call as a, I'm forgetting the word.
Synergistic divergence.
Yeah, synergistic.
It happens. And I think this is one condition where you probably have to do a large lateral rectus resection and not touch too much of medial rectus, even though a patient may have esotropia.
I'd seen one case and I have operated also on that case.
Yeah, it is called synergistic divergence, and that can happen sometimes. In fact, your surgery can sometimes induce it. So if the lateral rectus is tight and medial rectus is also tight, you probably should recess both rather than just doing surgery on medial rectus. Otherwise, chances of synergistic divergence are very high. And I have seen patients, and if it does happen, then you may have to tackle lateral rectus.
I must share that I have seen one case and operated one case also, and I had operated on that case, and in that I had researched both lateral recti, and with good results.
Yes.
Is there any role of shifting the insertion of recti when you are dealing with upshoots?
That she is very well covered.
No, I don't think shifting does. Y-split actually works very well for us.
Yes.
But then if you are recessing medial rectus, that time if we just shift the insertion while recession?
There has been a little bit of innervational part of the some patients do have upshoots which are innervational in nature because of the abnormal innervation to superior rectus or inferior rectus from the third nerve muscles. So innervational, if it is there, sometimes shifting inferior rectus towards the lateral rectus or superior rectus towards the lateral rectus has been described. But I thought this patient presentation was little bit, so I did not deal with it in detail. But yes, in those patients, you may have to shift vertical recti accordingly.
But not the horizontal recti.
No, horizontal recti, you don't have to shift any.
Dr. Vinita, I think we must pass on the clear messages and common procedures which are effective. We should not discuss.
We should not get this. True.
Yeah.
No, but what happens is most of the doctors Most of the doctors, they are hesitant of dealing with the superior and inferior rectus. So it's much easier to handle lateral and medial rectus.
Dr. Vinita Madam, the classical teaching is for this Y splitting is effective procedure for retractions. This must be the message which should be carried to the general practitioners.
Exactly.
Anyway, Y splitting involves only operating on lateral rectus, so don't worry about it. You can.
Yes.
And sometimes posterior fixation.
You should treat rectus as rectus. It is okay if it's superior or inferior.
In large iso deviation, you can also put a posterior fixation suture in the other eye.
Yes.
You can try that.
Dr. Jethani, you want to say something?
Yeah, just a quick comment that in innovational DRS, it is easy to differentiate innovational DRS from mechanical. You will have a primary position hyper or hypo in innovational DRS. It would be a good hyper. And in innovational, in a structural or a mechanical DRS, you will have both upshoot and downshoot. Whereas in innovational DRS, you would either have upshoot and downshoot depending on which particular muscle is. So it is just to tell that you can easily differentiate it. It is not that you can't differentiate it easily. Just a quick question from Sumita Madam about SRT. Some patients do improve with the SRT and some patients actually do not. Now, I was presenting this at a meeting and Dr. Gogit from Turkey said that patients, when you tell them to look upwards, some of the DRS patients, the eye would move, the eye would abduct in type 1. She believed that those are the patients who would actually improve and rest of them will not improve. I just wanted to know your opinion.
I haven't done that many SRTs to really answer your question with personal experience, but probably SRT, if there is a lot of, again, severe co-contraction and severe retraction, probably it is contraindicated. You should not do SRT in those patients. One. And as Dr. Birsen, probably she does a huge number of patients for almost everything. I don't know. She has 100 patients of third now, 100 patients. So her experience is probably she's a very good observer. So yes, I probably agree with her that probably every patient should not offer SRT. But I would do SRT if there is patient's main concern is motility limitation. If there is no severe upshoot, downshoot or co-contraction, no severe retraction, I would probably offer that procedure to the patient, definitely. If it is if it's a simple DRS and not
type 1 DRS with not significant retraction and slight ESO, if it is there, it is good. But the prognosis, I mean,
probably I will probably offer SRT.
SRT, okay.
Yeah, instead of touching both, because it.
Yeah, that's true.
Yes, but in children, my go-to procedure still remains bimedial recession, because if I'm doing young children, I would not want to touch superior rectus as the first. Although Dr. Kekunia's paper has reported good results in children, but I am a little conservative about.
No, I do agree, but also I wanted to ask about the incomplete DRS. Earlier we never used to see so many patients, or rather maybe we were not observant enough, but nowadays we see a lot of incomplete DRS, like -1, -2, and still having DRS.
Still having, all the features, I don't know. Again, I think there is a preprint in eye. Again, Dr. Kekunia has published their thing about incomplete DRS, where there is either no motility deficit or no upshoot, downshoot, nothing except esotropia. I have a patient, I had put it in our group also, where there is esotropia and narrowing of the fissure, big head posture, but absolutely no esotropia in the primary gaze. So I don't know how to deal with this patient. But he has face done like this, so much, no esotropia, no abduction deficit.
No nystagmus.
Yeah, no nystagmus. Probably has 10 prisms of esotropia. I've given him prism glasses. If he looks better, I will do surgery. But so you have to think on your feet in these patients. Every patient comes with something new.
Thank you so much. Now we move on to more difficult topic of nystagmus. So the practical pulse of nystagmus evaluation will be taken by Dr. Shashikant Shetty.
Dr. Vinita, I have a physical meeting at some distance
Yes,
place, so I have
yes,
to
you
leave.
are late and probably.
Thank you. Thank you, everybody.
Thank you so much, sir. Anyway, we have to leave panel discussion. Thank you so much, sir. Thank you for joining.
Okay, thank you.
My slides are visible?
Yes, sir. You are audible and visible. Please.
Yeah, thank you. Thank you, Dr. Vinita, for this excellent webinar. Good afternoon, everyone. I'll be talking on the pearls when you examine a patient with nystagmus, what all you have to look for. And we basically start from the history, so what you want to ask. So very important is the onset of nystagmus. That is very important. So which patients are included in this CMAS classification? They changed the terminology from which was earlier, which was put forward as congenital motor nystagmus and congenital sensory nystagmus. These patients are now classified as idiopathic infantile nystagmus. Why they choose to declassify this nystagmus? They found that the waveforms for both this congenital motor as well as the congenital sensory nystagmus were the same, and both had abnormality in the smooth pursuit. So they classified both this type of nystagmus into idiopathic infantile nystagmus. And so this idiopathic infantile nystagmus, what is the onset? When is the onset? So onset is from birth to 6 months, and anything nystagmus which the onset is beyond 6 months, which is called as a acquired, it goes into acquired nystagmus. So those patients has to be investigated. Birth history is very important. So you have to take a complete birth history, and you have to ask the history of like prematurity, any insult during the pregnancy or after pregnancy. So that is also important, which can cause idiopathic infantile nystagmus. And also you have to ask the history of head posture. So patient mostly, as Dr. Sumita had put forward, that patient had a very large head posture. So we have to look for the idiopathic infantile nystagmus. So these patients they may either keep their face turned to right, left, or they may have a chin elevation, chin depression, or they may have a head tilt to right or left. And we have to ask a history of whether there's a light sensitivity, like photophobia. A patient had difficulty in the night vision. No? All these patients who have like autosomal recessive RPs, they can present with nystagmus with retinitis pigmentosa. Autosomal dominant RPs usually present very late. And one of the things is oscillopsia. They might feel the objects are moving up and down. So oscillopsia also is common. It is very uncommon in patients with idiopathic infantile. You have to know the word uncommon. It is not very common, but they can still develop idiopathic infantile nystagmus, can also develop oscillopsia. If they have a sudden onset of strabismus or they develop field defect, they can develop oscillopsia. Oculodigital sign is very important. Parents may say, no, child is always frequently rubbing their eyes. So those it is commonly seen in children with vision loss, like in patients with Leber's congenital amaurosis. And family history is very, very important. So before you try to investigate the patient, so you have to look at the family members, carefully examine them. So sometimes when you look at those family members, you might not see any, because so you need to check their visual acuity, ask him to read something at distance. So any visual fixation effort can sometimes bring out nystagmus. Sometimes the parents, father may not have told the mother, he has this problems in childhood. He might have good visual acuity, and good visual acuity, but may had idiopathic infantile nystagmus, and maybe the amplitude might have reduced over a period of time. See in this patient, I can see this patient has a left face turn, and this patient is reading, and you can see the left beat nystagmus. So if the patient has a left beat or a right beat nystagmus, the face turn will be always towards a fast component. And what we need to focus in these patients, especially when you examine a patient with nystagmus? So you have to look at their initially, before you check their visual acuity, look at their head posture. If the patient is keeping a head posture, you need to measure their head posture. That is very, very important. And I feel the first visit is very, very important, because as the time goes on, patient may not keep the head posture as he was doing on the first visit. And also sometimes there may be change in the head posture depending on sometimes the nystagmus saccade might change. It might become from right bit to left bit nystagmus, then his face turn also might change. So you need to measure the head posture during each visit. You can either use goniometer, or you can use cervical range of ocular motion. This is a device which can measure the head posture in all the axes. So you can measure the head posture in, like, if the patient's got a face turn, a combination. Patient can have face turn, patient can have a chin elevation, chin depression, or patient can have a head tilt. So this machine is good. It can evaluate the head posture in all the three gazes. And when you look at the head posture, you have to measure both for near as well as for distance. And you have to keep looking at the patient, because sometimes patient can have a periodic alternating nystagmus where the head posture might change depending on the type of the nystagmus what the patient is having. And when you check their visual acuity, you have to give time to the patients, because patient might, because of the visual fixation effort, and patient is coming to a different surrounding, different place. So sometimes he may not read. So you have to give some time for this patient to check their visual acuity. And when they're checking their visual acuity, you have to check initially the binocular vision acuity, and you have to allow the patient to adopt the head posture when you check their visual acuity. And if the patient has got something called as manifest latent nystagmus, where patient may have, when you occlude one eye, when you check their visual acuity, you actually may increase the amplitude of nystagmus in the fixing eye. So that may reduce the visual acuity of the patient. So in those patients, you need to fog the other eye. You can use either a +6 to +10 diopter lens. You can place in the not to be checked eye, and then you check the vision, because that will allow some light to go into the eye which is not being checked. And then they may not aggravate the nystagmus in the vision, the eye to be checked. And as we told you earlier, that we check using the Teller acuity card, which has got multiple gratings. And then when we check patient who has got which got horizontal nystagmus, we keep their gratings little vertical. And if the patient got vertical nystagmus, we keep their gratings we keep them horizontal. And when you examine a patient with nystagmus, so what you have to look for in a patient who comes to you with nystagmus, you have to document the type of nystagmus. Okay, whether it's a pendular nystagmus, or it's a jerky nystagmus, it is a torsional nystagmus. So that has to be documented, and you have to look the nystagmus in all the positions of the gaze. Okay, so patient may have uniplanar, means the nystagmus will remain same in all the directions of the gaze. Okay, so that is usually seen in idiopathic infantile nystagmus. If the nystagmus changes in the other gazes, so you have to think it might be an acquired form of nystagmus most of the time. Then you have to look whether it's a symmetrical nystagmus or it's a dissymmetrical nystagmus. Whether the nystagmus is same, and as you see in this video, you can see the left eye, the nystagmus amplitude is more. So this is a dissymmetrical nystagmus. If it's a dissymmetrical, then you have to think there might be something, either vision in the left eye might be poor, or patient may have other neurological things which may be causing this dissymmetrical nystagmus. So when you see a dissymmetrical nystagmus, it's a red flag sign. Then you have to look whether it's a conjugate. Conjugate means, what do you mean by conjugate? Conjugate means both the eye move same, like both the eyes moves horizontal. Okay. Disconjugate means one eye is horizontal and one eye may be vertical, which is commonly seen seesaw nystagmus. Okay. And you have to look whether the nystagmus dampens with convergence. So if the nystagmus, so not all nystagmus will dampen with convergence. Even idiopathic infantile nystagmus may not dampen with convergence, but if it is dampening with convergence, you are sure it is not an acquired nystagmus. You have to look for fixation effort. If the nystagmus, most of patients with idiopathic infantile nystagmus with dampen with increase with fixation, wherein patient with vestibular nystagmus will reduce with fixation. Okay, so that is one way of differentiating a peripheral vestibular nystagmus with an idiopathic infantile nystagmus. And sleep, when the patient sleeps, will see an idiopathic infantile nystagmus will dampen, will reduce, and there will be no nystagmus, while in patients with acquired nystagmus, the nystagmus will be still persisting under a closed eyelid. What is Alexander law? Alexander law states that when the patients move their eye towards a fast jerk, towards the fast component, the nystagmus actually will increase, and towards the slow phase, it will reduce or nor reverse, which will be commonly seen again in peripheral vestibular nystagmus. So when you look at the nystagmus basically the defect is in the slow component. So there is it's a slow phase and tuck. There is a fast phase. So wherever is a fast phase, that is that way we denote the nystagmus. It's a right bit or it's a left bit. Okay. We can see the video. So when you look at this patient who has a left bit nystagmus, and you keep observing this patient, so now she changes to a right bit nystagmus. So this is a case of periodic alternating nystagmus. So periodic alternating nystagmus is it changes in periodicity every 2 minutes, which classically seen in acquired periodic nystagmus, which has a very classical reversal compared to a idiopathic infantile nystagmus, which will have something like a APAN, aperiodic alternating nystagmus. Okay. Now, if you carefully observe this patient, she has something called a seesaw nystagmus. So the right eye will elevate and intort, and the left eye will depress and extort. So right eye goes up, intorts, the left eye moves down and extorts. So it can be seen in patients in idiopathic infantile nystagmus who have achiasma, where the chiasma is not developed, or in patients with acquired nystagmus, in patients with paracellular tumors, in patients with craniopharyngioma. The commonest tumor which is presenting is craniopharyngioma. So ocular examination, what you like to do in these patients with idiopathic infantile nystagmus, you have to look for features of albinism, aniridia, congenital cataract. We can also look for patients with strabismus. So many of these patients with 30% of patients with idiopathic infantile nystagmus can also present with strabismus, and they may also have associated manifest latent nystagmus. And also look for paradoxical people. So what do you mean by paradoxical people? Paradoxical people is commonly seen in patients with Leber's congenital amaurosis and inherited retinal dystrophies. So when you switch on the light, what happens is normally the pupil will dilate. But in these patients who have paradoxical pupils, the pupil initially constricts and then slowly dilates. So this is very characteristic sign of inherited retinal dystrophies and in patients with Leber's congenital amaurosis. We need to do a detailed fundus examination to look for foveal hypoplasia and to look for other retinal dystrophies. And direct ophthalmoscopy examination also should be done to look it's like a Bruckner's test to look for strabismus and also look for a small amount amplitude of nystagmus, which can be missed with clinical examination. Investigations, what you like to do, we might like to do a visual fields, a color vision to rule out inherited retinal dystrophies. Iris transformations, very important. You have to look for iris transformation defects commonly seen in ocular albinisms or oculocutaneous albinisms, and also look at the parents. Sometimes patient may be autosomal recessive, autosomal dominant. When there is a dominant inheritance, the patient may be, one of the patient might be a carrier, or they may be an inheritance like X-linked. ERG should be done to rule out again retinal dystrophies, OCT to look at foveal status, and eye movement recordings. Eye movement recording should be done to look at the type of nystagmus, as someone had put up the nystagmus blockade syndrome and patient with FMNS, that is a fusion maldevelopment nystagmus syndrome. So that can be differentiated by eye movement recordings. Eye movement recordings is very important because nystagmus blockade syndrome can be a form of INS, where patient will use convergence to reduce a nystagmus, or they may induce convergence and reduce the nystagmus, convert it into a FMNS type of waveforms. Visual acuity, what you look for visual acuity? We do a vertical OKN. Vertical OKN is nothing but moving the drum and looking for optokinetic nystagmus. This optokinetic nystagmus is by the frontal eye fields, which relates it to the visual association areas, and from there visual association area of 18-19. From there it goes to MLF, and then you have the both the lateral rectus and the medial rectus, which are associated with a horizontal OKN. You have to look for vertical OKN in this patient with nystagmus. If you see a vertical OKN response with idiopathic infantile nystagmus, you know that patient will have good visual acuity. If you can elicit vertical OKN in a patient with INS, you know the patient has got good visual acuity and he will do good in school. You have to do a binocular visual acuity. Very important. You have to look at the binocular visual acuity in patient with INS. Vision in 9 gazes. Why you have to do vision in 9 gazes? So why vision in 9 gazes will help you to see whether patient has got 2 null points. Patient may have 2 null points. If you operate this patient may change the null point. So it's always important, and or patient may have a periodic alternating nystagmus. Vision should be checked for 9 near as well as distance, so that to look for 2 null points. Again, patient may keep 2 null points for near as well as for distance, and also to look whether the patient improves on near, suggesting that the nystagmus may be dampening on convergence. Check vision with Vergen's prisms. If the patient has got good visual acuity for near, you can try 7 diopters of base out prism with -1 diopters of lens, because this Vergens may induce convergence and may cause myopia, especially if the patient is pre-presbyopic. So in those patients, we can try 7 diopter of lens base out with -1 diopter of lens. Non-surgical management of patients. If the patient has got face turn, you can try prisms. And if you see a patient with head posture, and if you're not very sure if the nystagmus is there, always first try to close the eyes of the patient. Ask the patient to close both eyes, and then you look at the head posture. If the head posture is persisting, in spite of both eyes are closed, then you have to look for muscular form of torticollis. And then again, what you do, then you close again one eye of the patient. First close both eyes, then look for head posture. If head posture is persisting, then it is a muscular form of torticollis. Close one eye, again check for head posture. If the head posture is still persisting, then it's because of the nystagmus. If the head posture comes back with both eyes are open, then you have to rule out strabismus, because the patient might keep the head posture in patient strabismus to achieve binocular single vision. Always correct the refractive error in patients with nystagmus, and you have to look for with the rule astigmatism, very commonly missed. With the rule astigmatism, why it develops in patients with nystagmus is because the eyes are oscillating under the lid, and the lid compresses the cornea, causing the vertical meridian of the cornea to be more curved, causing a with the rule astigmatism, which can be always missed in patients with nystagmus. So keep the head in the null point and do a retinoscopy and always look for with the rule astigmatism. Patching can be done even if there is a patient with latent nystagmus, if their eye is amblyopic. So don't have to worry. Even if the patient has got a latent nystagmus, you can still do patching to improve the vision in the amblyopic eye, coexisting with nystagmus. Prisms can be given. If the patient has got a head posture of less than 10 degree, you can give prisms to reduce the head posture. Base out prisms can be tried. As I told you, 7 prisms base out with -1 diopter if the patient is pre-presbyopic to improve the vision in all the positions of the gaze. Acquired nystagmus we have to suspect in patients who presents with oscillopsia. If the patient feels that the motion is moving, no, it can be also there in patients with INS. In idiopathic infantile nystagmus can also present with oscillopsia. Alexander law should be looked at, where the nystagmus will increase in the towards a fast pace. It's also called as gaze evoked nystagmus. It has to be differentiated from gaze modulated nystagmus, where the nystagmus might change in different gazes. And in acquired nystagmus, usually it will increase on convergence. That's a inverse of idiopathic infantile nystagmus, where the nystagmus may dampen on convergence. In patients with peripheral vestibular nystagmus, it will reduce on fixation effort, while in patients with idiopathic infantile nystagmus, it will increase on fixation effort. Acquired nystagmus will present in sleep, while in idiopathic infantile nystagmus, where there is no fixation effort during sleep, it will reduce. So parents will say that when the child is sleeping, the nystagmus is reduced. And in acquired nystagmus, you will have soft neurological signs which will not be present in idiopathic infantile nystagmus. Points to ponder when you consider surgical treatment: age, whether we have to look at the age to correct this patient. So you should always measure the head posture, because the head posture can change. Patient can present with different head posture. Patient can have complex head posture. So you need to be completely sure that there is only one single head posture in which you need to tackle. And always assess. First you have to correct the refractive error in this patient nystagmus, and then you have to first give glasses, and then you have to assess with the glasses. If the patient is comfortable with contact lens, you can try contact lenses, because patient can also develop high astigmatism, and you can have toric lenses which can correct the required amount of astigmatism, or you can use soft contact lenses if the astigmatism is very less, because these contact lenses move with the eye. Normally with the glasses in the optical center is there, and the patient is keeping head posture, so patient may not look to the optical center. And if you give contact lenses, the contact lenses move with the eye. It can correct the optical and spherical aberrations, and it can also have a biofeedback mechanism, because this contact lens sits over the conjunctiva in the cornea, and it can also create a biofeedback mechanism to the brain, and it can reduce the amplitude of nystagmus. So that can also be tried in a little older children. And nowadays contact lens can come with tint, which can also reduce the photophobia in patients with albinism and cone dystrophy. So also look for a periodic alternating nystagmus. And then a lot of surgical procedures are there which can reduce the amplitude of nystagmus. And so when you are correcting nystagmus, you are not correcting the head posture, you are correcting is vision in all the 9 positions of gaze. So you are expanding his null point. Is a null point which is very small when he's looking at a particular target, which are expanding his null point, what we call as a naphax. The naphax is nothing but the nystagmus acuity function. Nystagmus acuity function, which increases, and we are doing eye movement recordings using iLink, which we do naphax measurement. I can have a small video of what we do, how surgery helps. stabilizes the eyes to improve the visual acuity in all gazes, expands the null zone, improves the head posture in this patient in nystagmus. I will just close. Sorry. Where is the presentation? It is loading. Actually, we do eye movement recordings for all patients with nystagmus. This is a small child. This is the target what we keep, and there is a tracker, eye tracker, which we track the patient with nystagmus, and we can document the type of nystagmus like this, which will show the fovation period, the fast phase, the slow phase, and it will give the, and we can really see how is a nystagmus, what type of nystagmus patient is having, and we have these parameters which will give the waveform analysis of these patients. So we can see the fovation duration, and what type of saccade patient is having, and we can look at their improvement pre-op and post-op, how the nystagmus has got better. And what we do is the waveform analysis. We do the pre-operative, post-operative, and then we look at the frequency, amplitude, intensity of the nystagmus, and the NAFEX. NAFEX is the new measurement of nystagmus. We can measure it, and then we can document and say whether it has really improved or not. So NAFEX can see pre-contact lens, post-contact lens, pre-glasses, post-glasses. This is how we measure, and this child who had a dissymmetrical nystagmus, this is eye tracker, which will track the eyes. And this shows the waveform analysis of the patient with nystagmus. And then it shows a fast phase. This is a state-of-the-art eye movement recordings, which can be used to document the patient with nystagmus. Thank you. Thank you for this opportunity.
Thank you so much, sir, for a wonderful presentation. As we are running short of time, and Dr. Alay has requested for the presentation. Dr. Pillai, you have to wait. We have to take a talk of Dr. Alay first. So request Dr. Alay Banker to present an overview of ROP management.
Thank you, ma'am. And I would like to thank BDOS for giving me this opportunity. I'd like to share my screen. I hope you can see my screen.
Yes, sir. Very well.
Yes, sir.
So I've been asked to speak on an overview on ROP management, the current guidelines. So, I would like to begin my talk is why is this very important in the current scenario? And we all know that ROP has been included in one of the health conditions which have been selected for child health screening and early intervention in the RBSK, the program. So ROP is an essential part of an examination to be performed as a routine now. and the most important, as we are hearing every day, new and newer medical legal cases are coming up, mainly regarding ROP. And, we've heard that the compensation has gone up as far as up to about 1.8 crores. And it is not just the pediatrician, but also the ophthalmologist and also the concerned hospital where the baby has been admitted. So all the three parties can be involved in this litigation, and hence it is a medical legal issue now. And it is extremely important that all premature babies which fall under the screening guidelines need to be screened for ROP. So I'm not going into the details, but as we are going to look at the management part, just a brief overview of the classification of ROP. And this is the stage 1, where you can just see the demarcation line temporally. Then comes the stage 2, where you see a thick ridge developing, which has the height as well as the width. And these are essentially, the non-threshold disease, which essentially does not require treatment. But then onwards, when you go to stage 3, which is basically a ridge with the extraretinal fibrovascular proliferation, where you see these vessels, they go up into the vitreous cavity, and these stage onwards are the treatable or the threshold ROP stages. Furthermore, the stage 4, which is essentially the retinal detachment, 4A is the peripheral detachment, and 4B is where it involves the fovea. And these stage onwards, essentially you need surgical treatment for the management of ROP. And lastly, unfortunately, we still see today a lot of cases. I see almost about 4 to 5 cases a month, which come to us with stage 5 ROP, essentially presenting with a white reflex in the cornea and, essentially lost eye. There is also other associated symptoms, signs where we have defined new ROP diseases, which is the plus sign, where you see the dilated tortuous vessels. And then these are the different zones. And this is also very important when it comes to management. The zone 1 is the posterior zone. The zone 2 is where you go nasally up to the ora and temporally up to the equator, and then the peripheral zone 3. So coming for India, the screening guidelines are different. We usually like to screen all babies born under 2,000 grams, less than 34 weeks. Also, there are certain high-risk cases which have to be screened, like RDS, multiple pregnancies, apneic episodes, and also certain larger babies who have had a stormy postnatal course. So very, very small babies might require screening at a very early age, within 2 weeks of birth, but normally the dictum is that the baby should be screened within 30 days of the birth. So coming to the management, I usually say that it involves the 3 C's, that is the consent, the communication, and the care. And I think the first 2 are most important, that is the consent and the communication, because it is very important to explain to the parents that management of an ROP is a lifelong process. It is not a 1 stage or a 2 stage. It is a lifelong process. It involves consent and understanding of the disease by the parents. The treatment depends on the stage and severity. And as I said, if there is a mild stage, you don't need to treat, you can just observe. And basically, the treatment has been divided into pre-threshold and threshold. And the threshold disease essentially requires very urgent and prompt management. It involves stage 3 with extraretinal fibrovascular proliferation, more than 5 contiguous clock hours or more than 8 interrupted clock hours, and all cases with plus sign. The others are the pre-threshold, which might need just observation and very, very close follow-ups. So the treatment, as I said, the first part of the treatment is either observe, and then there is the standard of care, which is the laser. The newer treatments, which are the anti-VEGFs, are a combination with laser. The older treatments, which is cryo, which is almost obsolete now, and again, an upcoming therapy, surgery, which we are doing more and more in early cases now. So let's look at an example. This was again a premature child, the PMA of 39.3, POG of 28 with a birth weight of 1380. And if you see here, this is just the stage 1 disease which the baby has in the right eye. So essentially this baby just needs follow-up. This is the left eye again of the same baby. You can see the extreme periphery, zone 3 disease. This is again stage 1, almost shifting into stage 2 with a thickened ridge. But again, these are non-treatable cases. You like to follow them up, and if you see on follow-up, the patients show complete resolution and complete vascularization right up to the aura. Again, the left eye, you can see how beautifully the ridge has disappeared, and you can see the vessels reaching right up to the aura. So laser is still the standard of care, and the laser that you do in ROP is very different from what you do in other retinal diseases. Essentially, you have to do a very, very confluent laser in the extreme peripheral avascular retina. You have to destroy the entire peripheral avascular retina without leaving any normal retinal tissue in between. I would like to point out that in most cases, we do this laser under topical anesthesia. It does not need any anesthesia in this premature child. However, if the laser has to be given in an older baby, 6 months or 8 months old, more so in this anti-VEGF era, you might have to give a short anesthesia. And this is how the laser is done with an indirect laser. Again, here there has been a lot of controversy whether to use a diode laser or a double frequency YAG or an argon laser. And it's essentially shown that any type of laser gives you the same results. But doing laser is extremely important. And this is one example how you should do the laser. You can see this was threshold stage 3, and the entire peripheral retina has been ablated confluently. This is the temporal part. You can see the nasal area also, and there was some elevation. So you leave that area and just go posterior and anterior to that area. And again, this is the left eye of the same baby. You can see how confluent and nice laser was done. And not like this. You see many cases referred to us. You can see these scattered laser marks. And, patients have been told that laser has been done, and you can be assured everything is fine. So this is not the type of laser that has to be done in ROP, and that's why I'm showing you this. Again, this is again the left eye of that same baby. You can see very scattered laser. So this is not how the laser should be done. It should be very, very confluent. Coming to the newer treatment avenues of using anti-VEGF, and we were one of the first ones to use that way back since 2006. And since then, you all know that this has been mentioned even as guidelines by the American Academy of Pediatrics, where anti-VEGFs can be given in patients with zone 1 stage 3+ ROP. The landmark paper of the BTROP study, which was published in New England Journal, and later on of the Rainbow study, which essentially uses ranibizumab. And this was one of the 2 multi-centered placebo-controlled trials which have been published in the literature comparing anti-VEGF with laser. And essentially both studies show that anti-VEGFs have a role to play in the posterior disease. And this is just the summary of the BEAT-ROP, which shows that the recurrence rate was reduced using anti-VEGF, particularly in zone 1 disease, as well as the posterior zone 2 disease. So what are the do's and don'ts for anti-VEGFs? According to me, they should be used, they can be used even as monotherapy in cases with type 1 ROP, but they should have a flat neovascularization. No case which has neovascularization going into the vitreous should be given anti-VEGFs. It is almost a treatment of choice now for aggressive posterior ROP as primary therapy, followed by laser. It can also be used as salvage therapy after failure or progression in laser. And it is also used before surgical intervention in certain cases of stage 4 or stage 5 ROP. The right indication, the right time, the right technique, and most importantly, the right follow-up and right counseling. These are extremely very, very, very important factors to be taken into consideration when you are using anti-VEGFs for ROP. So this is what I do in my practice. You have to explain to the patients that this is a lifelong disease, you will need long-term follow-up. And this is true even for laser. You hear in conferences that there is a controversy that when you give anti-VEGFs, you need longer follow-ups. I say the same to even my laser patients, that even if you have received laser, you need longer follow-ups. And I'm sure you pediatric ophthalmologists know it more than me, that these babies have to be screened for any eventuality, refractive errors, squints, etc. There are certain don'ts when using anti-VEGFs, because we all know that there are long-term safety issues, there are issues with recurrences and complications. So you have to be careful and select your case while using the anti-VEGFs. So I'm just going to show you a few examples, the real life scenarios of my experience of anti-VEGFs. And this was one of our first cases, a severe AP-ROP, and you can see this baby, pupil not dilating, persistent tunica vasculata lentis, as was previously described as rush disease. So we gave the Avastin, and just 3 days post Avastin, you can see the pupil started dilating. And this baby then went on to receive laser. She's 14 years old now, and you can see how heavy the laser marks look like when she is this old. So we were able to salvage, and here she is having 6/9, 6/18 vision as of today. We also structurally follow up all these patients by doing OCT of the retina as well as of the EDI of the choroid. And we've not started also doing the peripheral visual fields in these older babies. As compared to this, we had another case again of stage 3 threshold disease with AP-ROP. And you can see the severe neovascularization, dilated tortuous vessels. And post Avastin, just 3rd day, actually, you can see complete disappearance of the neovascularization. This is the adult photo, almost 14 years old now, of the same baby. And you can see has very good preserved peripheral fields because we have not given laser to this baby. We are still following up, and has almost full vascularization, almost up till 1 disc area from the ora serrata. The advantage of anti-VEGF, it can be given to very sick babies, even in NICU, as it is given only under topical anesthesia. It immediately halts the neovascularization. And I think a very important use, it can be given in babies who have very rigid pupils, non-dilating pupils, and in hazy medias. It also reduces the chances of peripheral visual field loss, reduces the chances of induced myopia and cataract. And of course, it is very cheap. So it can be given in peripheral centers in very severe cases where you can buy time, where you can give the prompt treatment and then refer the babies to higher centers for further lasers. How to follow up? I think this is a multi-million-dollar question. This is very, very important where you've given anti-VEGFs. You have to be careful about their late recurrences, the adverse events, the peripheral avascular retina, and in certain cases, you can see the crunch phenomenon or patients who develop acute traction retinal detachment, picture very similar to FEVR in adult age. So as I mentioned, most importantly, you have to look for recurrences. And I think most of us who use the anti-VEGFs now try to do the fluorescein angiography in their later ages and find out the extent of the vascularization or ischemia and probably add laser in a later age. So currently my strategy is I use anti-VEGF as primary therapy in all AP-ROP cases, posterior zone 1 or even half zone 1 cases. I follow up these babies, and if the growth is beyond zone 2 anterior, then I still keep following them up. If the vessels does not progress beyond zone 2, I immediately laser them up. Again, just to show you a few examples, this was a case who had different kinds of anti-VEGFs. This is a case who had Lucentis. You can see the left is the acute disease and the right is the response after Lucentis. Again, the pre-treatment and post-treatment. This was a very severe case which received Lucentis with laser combination. So you have to justify and decide what kind of treatment has to be given first. This was again a case of Lucentis monotherapy. This is a severe case of APROP, where you all know laser cannot be given as primary therapy. So this is after 2 weeks. The threshold or the APROP disease is now quiet, and now maybe you can add your peripheral laser. These are again the hybrid cases, very severe. You can see the looping of the vessels, which does not go beyond the zone 1 disease. You give the injections and the vascularity progresses. This is very, very important in hybrid kind of cases. You can see this very severe hybrid cases, how nicely it responds to the anti-VEGF treatment. And nowadays we are seeing more and more cases like this, which is the oxygen-induced retinopathy or the half-zone ROP, where there is vasculature only in the peripapillary area. So you give the injection, and most of these cases are extreme premature babies, very low birth weight. They might need 1 or 2 injections, and then once the vessels reach the zone 2 anterior, you can add your laser, thereby decreasing the destruction of the peripheral retina. You can also use the biosimilar Razumab, and just showing you a few cases, you can see this, a very severe stage 3 threshold disease, and it nicely responded with 1 single injection of Razumab, and 5 months down the line, you can see it has almost completely fully vascularized. So we are following up these babies. We have now almost 5 years follow-up. This is again a case of APROP. You can see severe APROP, and this is following a single injection of Razumab, has shown resolution with vascularization reaching almost up till zone 3. So this baby, we are now planning to do laser in the peripheral retina. Again, another case, very severe case. You can see stage 3 and APROP. You can see the severe APROP disease and how nicely the APROP disease regresses. There is still a lot of avascularity. So you keep following up these babies, and you can see the vascularity now reaching in zone 2A, and then you can add your laser. So this is a baby which is now scheduled for peripheral laser. The safety profile, we do not know. There's a lot of controversy. There are a lot of papers in the literature. We also follow up our babies with ERG, and all babies undergo neurodevelopmental analysis. And most of our babies have shown that there are no issues as regards the neurodevelopmental analysis are concerned. These are the wide field fundus. We also do wide field fundus angiography as well as photography for all these babies. Just last 2-3 slides about our program, community program that we are running here. We run a ROP screening program with PPP, which is the Polio Foundation, and this is our team. We have the Red Cam, which goes in a van, and we visit about 5 to 6 districts. And this is the daily schedule, week-wise. We visit all the public as well as the private sector hospitals. The public sector hospitals provided complete free treatment as well as the screening, and this is how we see the mothers lined up in the public hospitals. We are now extensively using the Forus camera, and this is a very, very good camera. We provide detailed reports to all the parents. These are the cards which are given to the parents, and also to the referring in ICUs. Detailed reports are given every single day. And all the images are uploaded, and we also do telemedicine through even the apps on the iPhone. And we were very fortunate that our late President Abdul Kalam and the astronaut Sunita Williams had visited our hospital and have blessed our program. So you can see the difference. We want to prevent blindness from ROP from going into this. And we have now over 30,000 babies screened, and we have treated over 1,000 eyes in the last 8 years. So just to conclude, we should remember the 30-day strategy, ocular examination before 30 days of life, and early before 20-day in extremely premature infants. Thank you very much for your patient hearing.
Thank you very much, sir. It was an excellent presentation with a huge experience of having such premature babies treatment, and with the excellent photograph. Just because of the shortage of time, we are not asking you questions. We have overshooted our time. And there is one more talk from Dr. Ganesh Pillai's long awaited, Pearls in the Management of Cataract. Please.
Thank you.
Good afternoon, everyone. Management Pearls of Pediatric Cataract. Thank you, Nita ma'am and Bdos, for this opportunity to talk on this very interesting topic. Darshan Kokar sir, for teaching me this art of pediatric cataract surgery. I have no financial interest. The Indian scenario of pediatric cataract is almost like 15% of the childhood blindness is attributed to pediatric cataract. Cataract surgery is one of the most cost-effective healthcare intervention in terms of quality of life restored. A child lives almost at 70 years, and if we can give vision to these children, we can give a very workable 70 years of life, a workable vision. Now, amongst these pediatric cataracts, around 25% are hereditary in nature, 15% are syndromic, 10% are infectious, and around 50% are idiopathic still. So identifying, how does the identification takes place? Basically, most of around 41% of these are incidental findings. Others are basically leukocoria and strabismus that they present to us. So we have to identify whether this opacity is anterior to the lens, lenticular or posterior, which can be easily done with a direct ophthalmoscope. Other investigation modalities like indirect and USG, UA and CT scan may be required as per the disease. Evaluation, a detailed history, including family history, especially in case of syndromic babies and autosomal dominant recessive and X-linked family members need to be screened also. A history of onset of lenticular opacity, laterality, and progression is also very important. A prenatal history, including any maternal drug intake, febrile illness, rashes is also very important. Birth history, especially birth weight, should be looked for. Developmental history should be carefully assessed. Visual acuity assessment has already been discussed previously. Grossly, at a distance around 30 centimeters, you should look for fixation, whether the fixation preference, object to occlusion should be also be checked. We should look for central steady and maintained fixation or not. In younger infants with poorly developed fixation, a red reflex test can be performed in a darkened room with a direct ophthalmoscope along with undilated retinoscopy to assess the visual significance of the lenticular opacity. Visual acuity assessment, a central cataract which is larger than 3 millimeters in diameter, a unilateral cataract which is associated with strabismus, and bilateral cataract with nystagmus are considered visually significant cataracts which require prompt treatment. Asking about the visual interaction of the child at home with the family members helps in determining the severity of the visual dysfunction. At 2 months, basically, the child makes an eye contact with the mother. If it is delayed, you should always try to screen the babies. As already given these cataracts. Visual acuity in older cooperative children with preferential looking card test, tellers in Cardiff, and pattern BR wherever necessary should also be done. A physical examination to see for the other syndromic features, especially in cases of Marfan's, Conradi, Downs, should also be looked for. Microcephalus and hydrocephalus is also something that you need to measure. These cataracts can present to us in different morphologies. Investigation is basically in cases of bilateral cases. In unilateral cases, investigations are necessary if there is any positive maternal antenatal suggestive of infection or presence of microcephaly, deafness, cardiac abnormalities, where torch needs to be done. In bilateral, you should always try to screen these babies as per the disease suspected. These are the investigation. I won't go into the detail because of lack of time. Basically, the debate remains primary versus secondary implantation, biometric measurement and its accuracy, post-operative target refraction in these babies, IL selection and IL power calculations are the debatable topics. Now, the first question is when to operate. Visually significant cataracts in the central visual axis, a size which is more than 3 millimeters, any posterior cataracts, retinal details where it is not visible at all, nystagmus or strabismus which is associated, poor central fixation even after 8 weeks should be promptly operated. Time of surgery, again, any cataract which is unilateral should be operated as soon as possible. Generally prefer to do it after 1 month and less than 6 weeks of age. Bilateral cataracts can be still waited upon till 10 to 12 weeks. The risk of amblyopia is relatively less in a bilateral cataract compared to a unilateral one. If it's visually significant, again, obviously we have to operate it early. Now, what are the surgical challenges of operating a pediatric cataract? Basically, these are small eyes with a shallow anterior chamber, low scleral rigidity, poor pupillary dilation, thick and elastic anterior capsule, requirement of a posterior capsular access, as well as anterior vitrectomy is something that you need to learn. So primary versus secondary implantation. So whether we should go for a primary or a secondary implantation, I think the debate about 2 years of age is not there. Every child over 2 years of age is definitely given an implant, but less than 2 years, it remains a choice. So primary implantation, what are the challenges is the IOL power calculation, because in the first year of life, the axial length increases very rapidly, as well as the keratometry reduces very drastically. Unpredictable post-operative refraction, more reaction in the anterior chamber, and membrane formation is there when there is a primary implantation. If we go for a secondary implantation, what are the disadvantages? Basically, there is a risk of amblyopia. Compliance and handling of the contact lenses in Indian scenario is very difficult. It's not cost effective because you need to follow up regularly, maintain a very clear and clean hygiene. There is always a risk of infection if we go for a secondary implantation. So how to select an IOL? Now, whether should we emmetropic, we should leave the child emmetropic or undercorrect the child. So we should look for what are the advantages and disadvantages, again, choose as per the patient. So what are the advantages of keeping the child emmetropic? So the child might not require any spectacle at that point of time, which may prevent amblyopia. But the disadvantage is the child may have a very large myopic shift eventually, which will require a secondary procedure like an IL exchange or a refractive surgery later on. If we undercorrect, the spectacle or the contact lenses use will be necessary initially to avoid the risk of amblyopia. But the advantage remains, there is increased chance that the child will be emmetropic in the adult age or maybe slightly myopic or hyperopic as per the axial length growth. But still it remains an unpredictable growth of pediatric eye. Now, how to calculate the intraocular power in these children? Basically, different formulas are there, but we try to do a graded correction rather than a uniform one. A less than 6 month age child, we try to undercorrect by 15% using the SRK2 formula. Less than 1 year, around 10%, around 1 to 2 years, around 7 to 8%, 3 to 4 years, around 5%, 5 to 6 years, around 3%, and more than 6 years of age, we don't undercorrect the children at all, or slightly hyperopic. So preoperative evaluation, axial length measurement, immersion scan is the best. Axial length drastically increases in the first 6 months. It's almost 0.42 millimeters per infantile stage, reducing gradually. And probably by around 6 years, it settles down totally to an adult size, or very slow growth happens after that. Keratometry similarly stabilizes by around 3 years of age. Handle keratometry without speculum is best. Here we are doing a UBM in this child, where we put a cone in the eye, fill with saline, and look for any posterior capsular defect where there is a suspicion of a posterior capsular opening pre-existing. Now, surgery in these patients, so a few pearls about it. Basically, visco-cohesive OVDs overfill the AC initially so that we get a good rhexis. Vertically, we give a nick in the center, post which we use intravitreal forceps, or even intravitreal Otrata can be used. The incision made is enlarged, and with the help of Otrata, we do a rhexis in these patients. Here we can see the rhexis margin is almost equal to the nucleus, which is there. Grasp and regrasp is the technique which we use. Generally, we keep the rhexis margin, rhexis size to less than 5 millimeter in size, so that we get a good IOL optic capture, coverage 360 degrees. Multi-quadrant hydrodissection, coaxial bimanual irrigation aspiration is done with a good posterior capsule polishing, so that we leave little amount of these lens epithelial cells. Underfill the back while doing the posterior capsular rhexis, don't overfill it. Then we give a vertical nick. Using the forceps, we try to make a rhexis which is around 3 millimeters in size. We don't make a large rhexis because the rhexis size increases in size when we implant the IOL in situ. So gently grip it, make a small rhexis. You can even also stain the posterior capsule for better visibility, and we complete the rhexis. Anterior vitrectomy is required in children less than 4 years of age, also done in children around less than 6 years of age. Formed vitreous, because it's of a formed vitreous, we don't expect any expulsive. Approximately 2 millimeter of anterior vitrectomy is done. Even posterior capsular rhexis and anterior vitrectomy can be done from the posterior route using the pars plana with a vitrectomy cutter. But the manual capsular rhexis is definitely stronger than the vitrectomy cutter. Use a high cut rate and a low suction. IOL in the back implantation, IOL is inserted in the back, enlarging the wound. Wound should not be tight. We should at least go inside a millimeter and then inject the IOL, so that we have a proper placement of the anterior haptic touching the posterior aspect of the anterior capsule. Basically, a controlled screw insertion is better than a injector. Intraoperative consideration, child less than 2 years of age, we do a lens aspiration with PCC and anterior vitrectomy. Child between 2 years to 6 years, we do a PCC plus minus anterior vitrectomy. But a syndromic child, we definitely do an anterior vitrectomy. A child more than 6 years, we do a lens aspiration and PCI implantation only. Only in a neurologically not so good child, we do even a posterior rhexis in these children. Complication, immediate post-operative complication are there because the blood barrier is not that good in these children. Hence, a severe inflammation and inflammatory membrane formation can occur. A course of steroid and homide is essential in the post-operative period. A pupillary block can occur because of the small eye and the air which we inject in the AC. Wound leak and loss of anterior chamber can also occur. Hence, placement of sutures in all the wound, that is including the MVR entry, should be done. Synecdoche formation can occur. Visual axis opacification at age less than 6 months is quite common. It's almost 30% of these children. Age at surgery is more than 6 months, we expect a little less visual axis opacification. With a good anterior vitrectomy, even these rates are less in Indian scenarios. pre-lenticular and retrolenticular membrane formation may occur, which will require vitrectomy cutter, using vitrectomy cutter removal. Glaucoma is fairly common in these children in ages which is less than 9 months of age, relatively less in more than 9 months of age. A PI is with +3 near error. Executive type glasses are preferably given to these children. Bilateral aphakia, high index glasses should be given to these children. Surgical advances which has been recent uptrend is basically there are plasma updates, vitrorexis under electron microscope shows that basically manular access is much better than both these instruments. High speed vitrectomy cutter are there. Even Centurion has a 4,000 cut rate vitrectomy cutter. AutoSat is available nowadays. Active flutes and Ora is there for intraoperative IL power calculation. Intraoperative OCT with Rexis assistant is there for guiding the Rexis. Post-operative amblyopia management, amblyopia has been already discussed, but it is a very essential part of pediatric cataract treatment. Not only the intraoperative, but the post-operative management is essential in these children, and a regular follow-up is essential. So take-home message is that early identification and early surgical intervention helps in having a very good vision in these children. IL implantation as a primary procedure is much better in Indian scenario, hence it is indicated. PCC and anterior vitrectomy should be done in all children below 6 years of age. Suture placement should be done at all ports. We should not leave any port unsutured. Refractive correction and refraction is very essential in the post-operative period. Amblyopia therapy helps in getting a better visual outcome eventually. And last, regular follow-up is very important. Thank you for your kind attention. Thank you so much.
Thank you, Dr. Ganesh, for a wonderful presentation. With this, I think we have come to the end of our session, and I invite Dr. Jahavir Bindra for Thanksgiving.
Thank you, ma'am. It has been an interesting, informative, and exhaustive session on pediatric ophthalmology. First of all, I would like to thank our panelists, Dr. Subhash Dadia sir, Dr. Cyril Kumar sir, for their innovative, expert comments. I would also like to thank our speakers, panelists, Dr. Shashikant Shetty sir, Dr. Surita Agarkar ma'am, Dr. Ale, and presentation and enlightening us. I would also like to thank our speakers, Dr. Kavita Gupta, Dr. Rashmi Apte, Dr. Pawan Chaurasia, and Dr. Ganesh Pillai. I would also like to thank INTAS for sponsoring this event and INTOD for telecasting it. And to sum up all, I would like to thank our entire audience who has been here since last 3 hours for this exhaustive session on pediatric ophthalmology. Thank you all. Thank you, everyone.
Thank you so much. Thank you, Dr. Sumita. Thank you, Dr. Shetty. Thank you, Dr. Sain.
Thank you, ma'am.
Thank you, madam. Salil, thank you. Thank you, madam. Thank you for this excellent.
Sir. Thank you so much, sir. It was our pleasure.
Thank you, sir.
It was a wonderful session. We wanted to ask many questions, but because of the paucity of the time, we could not do that.
Maybe they can mail us. We can write to them.
Sure. So
good suggestion.
Yes.
With this, yes.
You can appeal to the audience if they have any questions to the speakers, experts, or panelists. They can write to you and you can ask the concerned persons to give the reply. It's a good suggestion.
Yeah.
Definitely, sir, definitely.
That's good.
Thank you everyone.
With
So
this,
I also
thanks to all.
thank all the speakers and our guests who have been here on this Sunday and giving us their time. Thank you very much. And wonderful anchor Vinita and Shavir, you did a wonderful job. Good topic selection. Thank you all very much. Interesting and very nice, informative session we had today. Thank you.
Thank you so much, sir. Thank you,
Thank you, sir.
Salil sir. Thank you, Lalit.
I also convey my thank you to all of my seniors, speaker and panelists.
Thank you, Chawla sir.
Thank you. Thank you, ma'am.
And thank you,
Thank you.
Todd,
Bye,
for
everyone.
such a wonderful transmission. Thank you, the whole
Thank you,
time
Dr.
team.
Gajendra.
Thank you so much.
Thank you, sir. Thank you, everyone. That was a nice and wonderful interaction.
Thank you
Thank
to
you all,
the
guys.
entire. If we would have not been sponsored, we could have conducted CME. So thank you all. With this, we are just leaving this.
Bye, Salil sir. Bye, Vinita. Bye, Shavir.
Yes, sir.
Bye.
Bye, bye.